Good afternoon. Welcome. My name's Selina. I'm from the Australian Global Health Alliance, and I want to begin by acknowledging the traditional owners of the land on which we gather and meet. Here, where we're sitting physically, is the land of the Wurundjeri Wurrung people of the Kulin Nation, and pay my respects to elders past and present. I also extend that respect to any Aboriginal and Torres Strait Islander individuals here with us, and also extend that respect to all First Nations community, of which many of us are part of. So welcome to the 2025 Australian Global Health Alliance Congress. It's our 4th year. We run these congresses annually. Sometimes they're hybrid, sometimes they're in person, and this year they're both. I'm going to start with the most interesting news, which is housekeeping. If you need to escape, the escape exit is on my right, and if you need to use the bathroom, it's on the left. We are going to have quite a packed but fascinating agenda where we will cover topics from gender equality, planetary health, climate change and health, and humanitarian assistance. And we will do this in a series of snapshot conversations using a hybrid style. We have a brilliant lineup of moderators and speakers who've given their time in trust to us and to you for this time. We will have some break in between. And then afterwards, we will be looking at the future and what we are doing here in our region, followed by the amazing opportunity to co-launch with our Lancet authors here in Melbourne, the Lancet Global Health report on oxygen supply. But before we get to all of that, I want to start with introducing our welcome addresses. We will have a welcome by our chair of the Global Health Alliance, Professor Brendan Crabb, who's the CEO of the Burnet Institute and is also chair of Pacific Friends of Global Health, the secretariat we proudly host, and whose board meeting happened in person here in Melbourne. And we welcome our new board members who are here in the audience, Alopi and Pamela and Sarah. And I will hand over now to Professor Brendan Crabb for a welcome.
Sit in the hot seat. Thanks so much, Selina. Welcome, everybody. That's really my only significant job. Thank you to the Doherty, our great friends at the Doherty, for hosting us. I feel like I've given more talks and attended more sessions at the Doherty than I have at the Burnet in the last year or so. Very generous hosts, and thank you very much for hosting us and for being partners in our Global Health Alliance efforts. And thank you to the team, who I'll thank again at the end of the day for this very exciting program that we have today. Reimagining Global Health is a title we probably could have used at any Congress that we've ever had. It's always true. We always need to think and want to think about better and better ways of doing things. But I think it's a bit deceptively benign and doesn't quite capture the fact that we really need to reimagine global health. You know, the circumstance that we're in is one in which I think the Overton window in our world, and our world's a bit overlapping, of aid and global health and research and science and the application of science to the benefit of everybody, has shifted dramatically. It's been shifting, of course, for a long time, as everyone in this room knows. But with the new government in the US, what's acceptable, what's desirable, what's doable, what's been done is really shifted very substantially. And as I've had a number of conversations already today, including here, we're all kind of reeling from that still. I certainly am still reeling from it. You know, the sort of way of kind of the concept that we feel governments, and our government I feel still does have this, but the concept that that development and bettering everybody's lives, no matter what opportunity, what disability, what economic value, what age, what gender, the concept that bettering everybody's lives is good for everybody, which has kind of underpinned a lot of our work, is now, I think, has moved from lukewarm support to indifference. It's kind of been the Overton window for quite some time. Lukewarm support to indifference, to outright rejection and hostility, to where it is now. This is a very difficult space for us to occupy. And I don't have the answers to that. I just say that when we talk about reimagining global health, we can't talk about increments in change, because that won't match this step change in the Overton window of what's acceptable and what's doable now and what's behind that. You know, we really do have to reimagine global health as if millions of lives depend on it, because they do. So the good news there is, I think our world talks about bold reform a lot. We've got great ideas about bold reform, not necessarily certainty as to how you go forward, but we've got great ideas about it. And my challenge to everybody as we go through a session like today and then beyond that is that these ideas and the blue sky thinking that might accompany some of these ideas is no longer something for decades down the track. They are for now. Bring that sort of energetic zeal, bring that courage, the word Rachel Coughlin just used to me before. I think courage is so important here. This is a solution now, because so much does depend on it in our world. Business as usual is not going to deliver anything like what it needs to deliver. So that's the challenge. It is a a very difficult time for our world, and I can't sit here and speak as though I've got all the positive energy in the world behind me and our organisation and our wider partners, because we don't at the moment. We feel kicked in the guts, because we know what's the effect of these changes means to the lives of so many people. But that's our challenge. Reimagine global health. Let's really reimagine global health. Let's use this opportunity to really do things that we kind of know need to be done or should be done. Regionalisation, localisation, decolonisation. Make them happen so that we can go forward in a out of these ashes in a really positive way for the more medium and longer term. What I said about shifting Overton window definitely doesn't reflect every government, and our speaker that I'm about to introduce is most definitely reflective of that. Lucas de Toca is Australia's Ambassador for Global Health, and only a government who is serious about global health, about development in the region, would have someone like Lucas in that position. We feel very lucky to have him both as the head of global health and the head of the Centre for Health Security within DFAT, effectively thinking hard at a high level, as well as if you ever follow him on social media, he gets very granular wherever he goes. He's a community-minded, community-embedded type natural thinker. And I can't see Lucas behind me, but he's probably pulling faces at me. I just think we're extremely lucky to have Lucas. We had him introduce this Congress last year, which seems like yesterday, and we look forward to what he has to say. Can I warmly welcome Dr. Lucas de Toca?
Thank you. Thank you, Professor Crabb. Thank you, Brendan. And thank you, Selina, Georgina, probably, and everyone in the Alliance for putting this together and for the invite. I'm so sorry I can't be, once again, there in person. I'll make sure that the timing for next year makes it work, because our engagement with the Alliance is fundamental and one of my favorite parts of my job. I've only got a few minutes. We've got an international delegation already in my meeting room next door, so I need to go shortly. But we wanted to take a chance to address you at the beginning of the Congress. I don't have I have TPs, and I had a speech on a very brief speech on trends and broad things, but I'm conscious of two things. The first one is the more mundane one, which is that the government is currently operating under caretaker conventions until the outcome of the 2025 elections is known. So the ability to engage on policy discussions, as well as to make announcements, appointments, and major commitments is reduced, so as not to impinge on the freedom of movement of a return or changed government. But the other bit is the reality of what's happening around us, and Brendan's wise words and reflection on the complexity that we currently face and how it's hard to stay positive with everything that's going on. And I want to echo that. Like, I'm not going to come with a sort of stock standard government response on all the things that we are doing and how everything is fine. It is a very difficult time. The world is changing. There's escalating geopolitical tension. The global health architecture will have to change, and the overall development architecture will have to change. The significant withdrawal of donor funds, US, of course, but also others, European donors and others that are retrenching from some of their development commitments and shifting some of the commitments to defense budgets, means that a yet undetermined proportion of global health funding, but a significant proportion of global health funding will, in some form, not longer be available in the near future, which means that, as Brendan said, we will have to rethink what the system looks like. And I also agree with Brendan that we and everyone working in global health, everyone working in public health, and everyone involved in the COVID response, which in one way or another is pretty much everyone here, knows that all the cliches on not wasting good crisis are tiresome, but are true. And we've all recognized for a long time that our global health system needed reform, overlapping mandates, inefficiencies, organizations that operated with a degree of inertia, or that were set up in decades ago and are no longer fit for purpose. All those things we're aware of, and had been committed collectively, government and civil society and research world, to improve it, because we know how important these organizations is, because we care deeply about a world that is well coordinated, that cooperates, that collaborates, and that lifts standards for everyone. Because as a middle power, we understand that we can't go alone, and that a world that is governed by rules and norms is a world that supports Australia's national interest in the region and the interests of our region. We had a budget last week, and it was a fairly quickly delivered budget, given that many thought we would be in caretaker by then. But the budget made a number of statements in the international space at a time where we are seeing cuts in foreign assistance around the world. Australia increased, a modest increase, but increased its ODA to nearly 5.1 billion. We maintain or increase allocations to all Pacific and Southeast Asian countries, and we've increased overall the allocation to the Pacific nearly 100 million. The government also announced a new $81 million health resilience package, with the idea that will help backstop or plug some of the emergent need or or gaps that will be emerging as things become clearer. With that, the government wanted to do two things. One, to signal that while we are clear-eyed on reform options, Australia remains committed to the multilateral system, and you will have seen maybe in the budget that there were some deferrals or changes to multilateral payments, including moving a global fund payment to the following financial year, but no cuts. And that has allowed no cuts to health, and that has allowed to reprioritize some of that funding for immediate issues, particularly in the Pacific and Southeast Asia, including the emerging and growing, quite concerning HIV epidemic in Fiji, but also the maintenance of maternal and child health services and SRHR, with, again, the government specifically naming sexual and reproductive health and rights as one of the priorities that we focus on, and we have over decades, and in a bipartisan way. We've been the biggest funders of sexual and reproductive health and rights for a long time. But that doesn't minimize that the road ahead is difficult. It will be painful. We cannot use previous experience to necessarily predict what the future will hold, but that's what gatherings like this one, organizations that bring together significant expertise, care, people who really want to make the world better, and we see so much of that in the Australian Global Health community, and we see so much of that in any interaction with the Australian Global Health Alliance. So while I'm not full of chirpy positivity like other times, I am encouraged that we have the right elements to make meaningful change that will help mitigate some of the harm that unquestionably will result out of some of this change and is resulting out of some of these changes, but that we can harness that into a global health system that hopefully is more equitable, if on a smaller envelope, and is more efficient to deliver on climate, to deliver on equity, to deliver on less of a global north, global south divide moving forward. And I wish I was there to join the rest of the meeting. I too have been to more speaking events at Doherty than at Burnett and Brendan, just so you know. But I know that the discussions will be incredibly relevant for us. The work of the Alliance is fundamental. We interact with you in many, many ways, individually with members. We gather information, we receive ideas. Parliamentary friends groups are a fantastic way of engagement. We find this structure one of the key planks of fostering and harnessing the generosity of the Australian health architecture towards our region. And we're really grateful that we have that ongoing partnership and collaboration with you. So Brendan, I fully echo and respect and get behind the maybe not somber but somewhat solemn opening for this Congress, and I think it's important. Lives will be lost and have been lost as part of these changes, but I hope the commitment, which has historically been bipartisan, of the Australian government to global health, as evidenced in last week's budget, and our ongoing joint work to make a better world will remain. So not chirpy, but never pessimistic. Thank you, Brendan.
Thank you very much. Thank you so much, Luca. We're very glad that you are our Global Health Ambassador. The lights are being switched off in your office, so I think that's an indication that you need to get to your next meeting. But thank you so much for being with us.
Thank you, and hi, Adeeba. Sorry I can't say, but thank you.
So I now have the honour to introduce our keynote speaker in conversation with us, Professor Adeeba Kamarulzaman, who is our friend and our teacher. She's the Chief Executive Officer of Monash University Malaysia, Pro-Vice Chancellor and President. Professor Kamarulzaman is responsible for driving the university's initiatives to promote excellence in education and research within Malaysia. She is a distinguished and internationally recognised expert on HIV/AIDS and infectious disease. She was the president, as many of you know, of the International AIDS Society in 2020. And in 2021, she was appointed an inaugural member of the WHO Science Council with a remit to advise on high priority scientific issues that can have a direct impact on global health. Prior to joining Monash, Adeeba was Dean of University Malaysia's Faculty of Medicine. I don't have to say, for those of you who follow her work, that she's published hundreds of journal articles and has been the recipient of many awards, including the Advanced Global Award and the Australian Global Achievement Awards, the Madaka Award, and also Doctor of Laws from Monash University in 2015. Please join me in warmly welcoming Adeeba with a loud clap.
Thank you very much, Selina. It's great to be here, although I wish I could be there at the Doherty in Melbourne.
Yes, we're really looking forward to seeing you here again, but thank you so much for giving us time today. So as we discussed, we are going to be looking at the theme of reimagining global health today. And my two questions that we thought about posing regard both in terms of the current situation and your perspective, your very special, unique perspective, but also, you know, what we can be thinking about going forward in terms of opportunities. So from your current perspective as CEO of Monash Malaysia and also long-term global health and human rights advocate, also having been a leader in the HIV/AIDS movement, what do you see as the challenges facing global health today? What does our region do well?
Yeah.
Oh, so sorry, I did pause. What does our region do well? And also what do we need to be protecting?
Yeah, so thank you very much, Selina, and I naturally echo what Luca and Brendan have just said about this upheaval that we're all experiencing with this Trump administration and the assault on not just global health, but science and research in general. And then on top of that, I think today you all would have probably also woken to the news of the tariffs that, by the looks of it, has heavily affected our region. I mean, imagine Cambodia has been hit with a 48% tariff. Malaysia, 24%. So this is a very, very difficult time for us all. I, you know, in a very small way compared to the millions of lives that have been affected, have had my own Fogarty grant in implementation science training pulled away just a few weeks ago. Of course, it's nothing compared to what's happened to PEPFAR, Gavi, etc., etc. So that's the obvious challenge that we all have to put our collective effort and brains together to see how we can emerge out of this. The second, sort of to put the kind of I guess a doom and gloom scenario is, I think we kind of what keeps me awake at night, so to speak, is we collectively as a global health and the health workforce in terms of advocating to our policymakers, etc., but probably haven't kind of articulated the lessons learned from COVID as much as we could, in that I kind of feel, I don't know what it's like with the Australian government, but certainly in my own government and governments around the region, I feel that we haven't learned from it. We just want to forget it. And so it worries me a great deal, on top of what is, you know, the consequences of the Trump decision. So, you know, have we strengthened surveillance? Have we built the public health workforce? Have we strengthened the health system? So indeed, there is a lot to do. And I think, as I shared at the World Health Symposium last year, our region in particular have what I think are quadruple whammies. So we still face a lot of infectious diseases. leading with issues like antimicrobial resistance. We still have TB, MDR TB in many parts of the world, in India, in China. We're, with emerging infectious diseases that's lurking in our animals and in our forests. And as Luca mentioned, we still haven't got HIV under control after 40 years. And on top of all that, we have a rapidly aging population and are very, very vulnerable to the climate crisis. So starting off on a very negative, theme, those are the things that's in front of us in terms of global health challenges. But at the same token, I think there are many wins that we probably have not celebrated as much. We've done amazingly well in this region with malaria eradication, polio eradication, and in countries, of course, Australia, Thailand, Cambodia, in terms of HIV. So there are many lessons that we can learn from those successes. Perhaps I can stop there for now.
No, thank you very much, Adeeba. You talked about what we have going for us in terms of some of our successes. Beyond that, are there other areas that we should be thinking, building on from our successes in this region, that we need to really step up and protect, either protect through articulating it clearly or protect by reorganizing ourselves better?
Yeah, I think some of the successes, particularly around malaria eradication, polio eradication, came about from collaborations. It's not just, funding from the US, for example, cross-border collaborations, innovations, in-country innovations, and the use of technology, which was very widespread during COVID. And I think, again, the region is very innovative when it comes to the use of technology and working with communities. None of those things, like the malaria eradication and the polio eradication, would have been achieved without working closely with communities. Certainly, it's a shining example with HIV in my own work. I think we wouldn't have achieved the reversal of the epidemic in Malaysia without working with affected populations, particularly people who use drugs. And certainly that has been like Australia's leadership in terms of working very closely with affected communities and those at risk. Other things that we in the region, particularly the more wealthy countries within the region, it's as you all know, Asia Pacific, Indo-Pacific is so diverse, not just ethnically, but also in terms of socioeconomics. But there's much to be learned, I think, from efficient health systems like Taiwan, Hong Kong, and Singapore. Yes, they're wealthy countries, but coupling it with technology, there's probably things that nations, middle-income countries like mine, for example, can do more in terms of health system resilience, so that when and if the next pandemic comes, for example, we wouldn't have to scramble like we did the last time.
Thank you. And thank you very much for highlighting the role of communities. In fact, this morning with the Pacific Friends of Global Health Group, who advocates with Gavi, Vaccine Alliance and Global Fund for AIDS, TB, Malaria, we know that the governance mechanisms of these two multilateral institutions and initiatives have really entrenched community as part of the governing system, and that is really something to be protected overall. So just to my next part of the question and conversation. Back to the title of today, how can we reimagine global health? But for our region, Asia Pacific, you can speak to that as you wish, Adeeba. What are the opportunities for us? Who needs to be involved? And can you just share with us some of your craziest or your biggest hopes or wishes?
I think, yeah, so the retreat of the US, I guess, obviously presents a lot of challenges, but maybe some opportunities for global health leadership to shift eastwards. And by that, I mean Australia, Japan, South Korea, Singapore, if you include China and Taiwan as well, must step up to fill this void and foster better regional alliances and partnerships. I think we almost have no choice, right? And it's, in a way, it's kind of pleasing because Australia has been, at least in previous two administrations, have been making greater efforts from what I can see with, sort of economic partnerships with the Southeast Asian nations through even having a special ambassador for Southeast Asia. So I think those opportunities are there. And we recently heard even kind of traditional enemies like Japan, Korea, and China have come together from a trade, from an economic point of view. So perhaps we can reimagine a different world with Asia looking after ourselves, and that is if Australia heavily embeds itself as an Australian entity, as an Asian entity, and come together with all the other rich nations to support countries around her.
Thank you very much, Adeeba. So finally, just to end, one last very small question, but important one. Today, we're really proud that we have a representative from the Australian Medical Students Association Global Health to help us co-host this Congress. And I'm thinking about all the young people starting in global health or wanting to enter it, or just trying to decide what they're doing at university. There is a whole population and community out there that we have a responsibility to and for, even as we grapple with these very real and difficult challenges. Do you have any words of advice, hope, guidance for them, for us?
Yeah, I think certainly at the global regional level, it seems like public health, global health is gone, but that's not true, because at the national level, at the community level, you will always need public health experts. We still need to, like you said before, what do we need to protect? We need to protect science and evidence. We need to protect, for example, surveillance. We need to protect, the ability to collect data to inform our policies. We need to innovate and deliver on the climate and health catastrophe that's before us. So there will, I think, always be a role and a job in public and global health. Think locally and work, collaborate regionally.
Excellent. Thank you so much, Adeeba, for your time. And I hope you have a good day and rest of week. We will definitely be in touch and looking forward to seeing you here or there very soon. Please join me in thanking Adeeba for joining us. Hope you hear that. Thank you. So just to our listeners or joiners online, thank you very much for joining us at the 2025 Australian Global Health Alliance Congress. If you can't hear us or if there's anything going wrong on tech, email the Secretariat, or if there's a chat function, speak in the chat option. So now we're going to move looking at several themes in very strategic snapshot conversations. For those of you who don't know the Alliance so well, we have been strategically committed to climate change and health and gender equality, among other strategic objectives, for the last 5 years. Tomorrow, we're actually meeting in our first in-person board retreat for many years, and we will be looking at the future ahead for our community. In that regard, I'm really pleased to welcome for our very first thematic discussion, Dr. Danielle Stefanski, who is going to be our moderator, and she'll introduce the panel. She's an infectious disease and general physician. She's also an expert violinist. I have to put that there because it's amazing. And she's led programs and policies in HIV care and protection, rural healthcare, delivery and clinical mentoring, both in person and by telemed. In COVID times, she was the senior medical advisor in the Victorian COVID response. She's also worked internationally in the mid-2000s, in Thailand, also in Botswana, and for PEPFAR. She was appointed as staff specialist at Monash Health, and in April 2022, Danielle publicly announced her gender transition to female. Her workplace gender affirmation at a private hospital did not go so well, but subsequently she is proudly working as a medical advisor to a health tech company called Halixy. And now she advocates for employment rights for transgender and other marginalized people. And we are very proud to introduce Danielle today to discuss our first thematic conversation on gender equality. Over to you, Danielle.
Thank you very, very much, Selina, and everybody. It's my absolute delight and pleasure to be able to introduce the rest of our panel. So the topic that we are going to be talking about is gender equality, status quo, terminal or treatable. And did you want to come down, both of you? Yeah, I think that would be good. Hello, Meru. So I'm very excited to hear this discussion. I'd like to first introduce Professor Cathy Vaughan, who is Director of the Nossal Institute for Global Health and Chair of Global Health at the Melbourne School of Population and Global Health at the University of Melbourne. Cathy has worked as a researcher and practitioner in diverse settings in Asia, the Pacific, and with populations experiencing health inequalities in Australia for over 25 years. Her current research focuses on the impact of intersecting inequalities on health, and in particular on the ways intersecting inequalities shape experiences of gender-based violence and the effectiveness of violence prevention and response initiatives. This includes a particular focus on technology-facilitated gender-based violence in Asia and the Pacific, and strengthening responses to violence against migrant and refugee women and women of faith in Australia. Cathy is Director of the WHO Collaborating Centre for Women's Health and leads the co-design and consumer involvement node of the Methods and Implementation Support for Clinical and Health Research Hub at the university. Thank you, Cathy. Now I'm going to explain. I'm going to read through these bios quickly, and then I'll slow down for the actual discussion. And next in person with us, we have Dr. Jorjansan Jack Gunbatar. Jack is a queer rights activist from Mongolia and currently studying a PhD at the University of Melbourne. He has worked at a local LGBT centre for 10 years in Mongolia, in charge of health program, and has been instrumental in identifying healthcare system gaps and developing opportunities to improve access to healthcare for LGBTIQ Mongolians. He is currently undertaking his research focusing on the lived experience of healthcare access for young queer Mongolians and is doing a PhD at the University of Melbourne. And online, we have Associate Professor Meru Shiel, who is a vaccinologist and applied epidemiologist at the University of Sydney. Associate Professor Shiel leads the Infectious Diseases Immunisation and Emergencies Group at the Sydney Infectious Diseases Institute and Sydney School of Public Health and the University of Sydney. Dr. Shiel's PhD worked on developing vaccines for bacterial pathogens, and her postdoctoral training was on parasite immunology, focusing on malaria and visceral leishmaniasis. Meru is also a field epidemiologist with an MPhil in applied epidemiology from the Australian National University. Dr. Shiel has extensive field experience in Asia Pacific and also responded to international emergencies in Fiji, Dominica, Rohingya crisis in Cox's Bazar, Bangladesh, Tonga, and Papua New Guinea. Meru also co-chairs the Immunisation Agenda Strategic Priority Pillar on Research and Innovation and serves on the Data Use Working Group and is a member of WHO's Immunisation and Vaccines Related Implementation Research Advisory Committee. Lastly, but not least, Meru is a passionate advocate for women and diversity in leadership and is the current chair of Women in Global Health Australia, a grassroots movement with over 50 chapters globally. So, with this fantastic group of people, I wanted to start with a stock take. The Beijing Declaration is 30 years old this year. The UN Division of Women, in its review of 4 world conferences on women, stated, the fundamental transformation that took place in Beijing was recognising that only by a fundamental restructuring of society and its institutions could women be fully empowered to take their rightful place as equal partners with men in all aspects of life. In 2025, Kathy, what would you write on the report card?
Thanks, Danielle, and thank you for the introductions. You did really well to get through those. And apologies for the glasses. Sometimes when I'm introducing people, so I've been doing this since the mid-90s, I'm surprised, and then I realised that I can't read even grandma font, so maybe that's true. So I've printed it out very large, but I still can't see. The report card, I'll talk about my reasons why first and then talk about a grade at the end, which is exactly how you would mark an MPH assignment, all the good news and bad news and then the grade. I think, first of all, it depends on your view of social change. And I think up until fairly recently, people were perhaps content with incremental change and seeing that, people are chipping away and things are slowly getting better. But then you see what can happen in 2 months. In the last 2 months. And so actually social change can happen very quickly. And therefore I think that's a kick in the butt for all of us to work harder to bring about social change towards gender equality. I think that in terms of the aspirations of Beijing and the work of transforming and restructuring society and its institutions, there's a hell of a lot that needs to be done still, and that the chains of capitalism and colonialism are pretty tight still. I guess on the positive front, there's a lot more legal protection for women and girls than there was 30 years ago. There's been really strong momentum around gender-based violence legislation, with more than 95% of all the institutional mechanisms globally for protecting women around intimate partner violence having been established after Beijing. So that really did set up momentum around that. And 155 countries globally have some kind of domestic violence legislation in place now. So that is a big change, and we shouldn't forget that and recognise that that came on decades of work from unfunded, unsung women's organisations around the world. And there has been a lot of progressive legislative reform towards gender equality in many countries, but I'll come to the not so good news in a minute. There are definitely more services and supports for women in relation to health and in relation particularly to violence against women. So that might be around helplines, shelters, legal aid, training for frontline responders. So I think there's been definitely progress in that direction. Legislation banning gender or sex-based discrimination in employment. There has been some progress in that area, and gender gaps definitely have closed in education in many places, and growing awareness of gender inequality at the grassroots. So I think they're the positive things. However, there are very substantial global threats that threaten to undermine all of this progress and already are. So some of that is around global threats that exacerbate inequalities generally and kind of worsen the cracks that are already there in society. I mean, that's how we always used to talk about HIV, that it exploited the inequalities that were already there. I would say climate change is exactly the same, that climate change affects everyone, but it doesn't affect everyone equally, and that there are very gendered dimensions to the impacts of climate change in many parts of the world. We saw it with the COVID pandemic, and we're certainly seeing with this sort of growing anti-woke movement or anti-rights movement, the impact that that is having on women and girls globally, and on LGBTIQ folk around the world as well. I think that, whilst there's been some progress in legislative protection for women and girls in many countries, it's still illegal to have same-sex relations in 67 countries, I think it is. Jack, you may well talk more about this in a minute. And also numerous countries where different forms of gender expression are criminalised, and to be a transgender person is criminalised as well. And when you have, the leader of the free world announcing there will only be 2 genders henceforth, this is a real threat to transgender folk, non-binary people, but it also, given the close association between gender and sexuality, it undermines lesbian and bisexual folks' health as well, and has particular impacts for women who work in solidarity with queer communities. Intersectionality, we still don't do very well. So there's been progress for some women, but that's been unequal. So in Australia, for example, for migrant and refugee women, for women with disability, for women living in rural and remote communities, many of the opportunities that have advanced for white women, middle-class women living in the cities is not present for them, and that is replicated globally. There are more women living in conflict than ever before. Just a few years ago, the estimate was 612 million women living within 50 kilometres of an active conflict, and that will have increased. These are, figures from 4 years ago, so they'll have increased since that time, given the conflicts that we've seen globally, and I think that will come up in our last panel as well. Access to sexual and reproductive health, and it was great that Lucas rightfully spoke to Australia's commitment to sexual and reproductive health services. It's been a strong pillar of the Australian aid program for a long time, but that access is really patchy in our region and in high-income countries as well. Access to sexual and reproductive health care in the United States, for example, is a really good marker of inequalities in that society. Economic challenges remain for women. So whilst many women have been lifted out of poverty in the last 30 years since Beijing, there is still inequality in pay, there's inequality in access to different types of employment. And I'm very struck by the tariffs that were announced this morning and the extraordinary tariffs on Cambodia, Vietnam, Sri Lanka, Bangladesh, countries in our region, and the main exports to the United States from those countries is footwear and clothing, and they are women-dominated occupations. So the impact of this global disruption on trade is going to have very particular impacts on women and girls in our region. I don't know what Norfolk Island export to the US, but it's got a very steep tariff on poor little Norfolk Island. And so I can't speak to the gendered nature of those industries, but it's a bit surprising. I think women continue to be excluded from decision-making in many settings. Gender-based violence is an ongoing concern. Funding is fraught and fragile, but I won't go on with the terribly depressing long list of things that haven't improved over the last 30 years. So initially I thought, it has to be an F on the report card. But I work with so many extraordinary women and women's organisations in the region, and with fantastic colleagues working on queer health in the region as well, that I don't want to undermine the incredible efforts that have been made and the sort of, I guess, shoulders that that I stand on, and your shoulders, Jack. That I think it is a pass. Many things are better than 30 years ago, but it's not going to, it won't get you into a PhD, and this mark, and it really is nothing to be proud of, really. I think there's a lot to do still.
Yeah, I mean, I think what you're saying is that there has not been a fundamental restructuring of society and its institutions. Right,
No.
yes.
Correct.
So I will move on to the next bit, because we are going to have a more prolonged discussion soonish about reimagining, which is really the meat of it. But I'd like to just spend 5 minutes asking Meru and also Jack about the impact of the US government withdrawals. I don't really need to go through it in great detail to this audience, but USAID is gone, NIH research has been cancelled to, if it doesn't align with the regime. In Australia, with research partners to the US, we've had ideological purity questionnaires and the literal censorship of scientists by banning words such as women, inequality, female, gender, transgender, and LGBTQ. So it's been a couple of months. Meru, can we start with you, because you're remote? What impact is this already happening? And then I'll throw to Jack.
Thanks, Daniel, and apologies I can't be there in the room either. I'm calling in from the lands of the Gadigal people of the Eora Nation, and I pay my respects to Aboriginal elders past, present and emerging, and thank them for the opportunity to learn and grow on these lands. As an immigrant, I really value the opportunity to learn on these lands, and having spent much time thinking about this topic. And Kathy's really nicely covered and captured a lot of the issues. And as the chair and committee member of Women in Global Health Australia, this is something that we often are thinking about in my own work, which is in infectious diseases, health emergencies, where I guess is one of the fields where we probably hadn't recognized the role of women or gender more broadly until the pandemic, or until a few years ago. And we had seen a lot of shift in this area. Just one recent example that comes to mind is joint external evaluations, which assess a country's capacity to respond to acute public health emergencies like pandemics, but also natural disasters. There was the introduction of gender as a key domain, which I thought was great movement. And so we were progressing, and with these recent, I guess, geopolitical situations and changes, there's going to be a rapid decline and a regression on these ideas, be it collaboration with international universities, as well as particularly for those who are working on gender or women's rights, reproductive health, LGBTQ issues. I'm sure Jack will talk about these things. And when I was looking at the data, it looks like NIH provided about $11 billion annually to global biomedical and social research support. That's all been culled, and of that, a significant proportion was with gender. And I think the challenge with that is that the less we talk about it, it's going to have consequences. We've seen it for years and years that diseases or conditions that affect women are already under-researched. And by silencing and censorship of these terms, we're going to see less of these diseases or conditions being researched and prioritized. There's going to be less data on these things, that particularly disaggregated data. One of the things we always notice on leadership or positions is there's very little availability of data. And it's also a tricky time, I think, because we as a community are thinking about, do you stand by your principles? We're hearing a lot of researchers hide their gender research or even vaccine research. All of these terms are getting hidden. Do we stand by the principles that we believe in and keep doing the work? Or do you get the money and do the work in a hidden way? It puts people in a very difficult situation, and we lose the progress that we've made over the last 10 to 20 years around these issues and being more open and inclusive around gender research, leadership, women's rights. I'll pause there and we can come back to it.
Thank you so much, Meru. And Jack, with your on-the-ground organisation in Mongolia, what's happened so far?
So thank you. I'm so honored to be here today. I just need a couple of seconds to get my English back since I just came onto this stage. I think I'm good to go now. So I'm an activist before an academic. I am a baby academic doing my PhD, just started a year ago. But before that, I spent 10 years in a grassroots movement in Mongolia. And all of those reflections are very much based on my activist perspective. And I have been reflecting on our work and on the deep root of the movement we build and the paths we choose to take. So based on my experience, we often assume that substantial transformation must come from above, and believing that political and legal advocacy directed at the state is our clearest path to move forward. So which really, maybe perhaps it's very most appealing thing to international cooperation. Most of the fundings are in that field. But today, based on what's happening, today what we experience, people are calling it like in so many different ways. Activists use strong words such as fascism, for example, right? And democratic backsliding. But overall, this constant weaponization of hatred against trans people and stuff. So based on this, I question whether we have looked upward too much and downward and sideways too little. So that's my reflection as an activist, because when we think about social movement does not exist merely to secure institutional reform or transformation. It's the opposite way. So institutions should serve as a tool to strengthen the community. So what I'm really trying to see is like over the recent years, particularly, we kind of forgot how important, how crucial it is to cultivate strong, united communities from above. So that's
brilliant. And we're going to explore that and tease that out in more detail as well. Just before in the audience, you were saying that you're about to go back to Mongolia and that your organization's probably going to lie low for a little bit. Can you describe, what is going on with your colleagues and what their approach is?
So the organization I worked for 10 years is called the LGBT Center Mongolia. It is the first, so far up until recently, the only LGBTQ focused organization that was established in 2009, very young, but since 2009, we were pretty successful in terms of legal inclusion of queer people. By 2025, by now, Mongolia became one of the most progressive countries in terms of LGBTQ equality on the map, on the paper, but the reality is obviously very different. But US aid, the US government used this passive strategy across the region very successfully over the last, I believe, 50 years. And US aid was one of the most significant fund in development sector for so many years. Because of that, gender equality and all the other social rights movement, health issues became very dependent on this international donor, particularly USA donor money. And we all knew and kind of expected that what we just experienced for the last couple of months would come one day, but we failed to prevent it. We failed to respond timely. So right now, a lot of the civil rights movement, including LGBTQ movement in that region, suffers greatly. All important funding somehow related to US aid. And overnight, many organizations lost its funding, entire funding, because somehow it's always connected to the US. Even though it's a different organization, the core fund always comes from US aid. So because of that, many organizations, including my organization, are trying to stay low for a while. Because first, the funding's gone. Second, also this political environment is not very friendly. You know, the Trump, one of the most dangerous thing having Trump as a vocal person about all of those anti-LGBTQ, anti-gender agenda, it is very easy for other decision makers to get inspired. They're already inspired, but now Trump is really enabling them to just be more vocal about it. And all those legislative inclusion and achievement that we fought so hard for last the couple of decades, it can be reversed very easily. So this is the danger that we face, especially in queer rights movement across the region.
100%. And you've said that working with queer communities in Mongolia has been, let's say, a hostile environment. And we might be seeing now an acceleration of that, or an emphasizing of that. How have you and your organization dealt with working in a hostile environment, and what can we learn, in the audience from your experience, and how do you think you might need to adapt to that now, as you would expect the political environment to get worse?
I don't know, to be honest. I don't know how to answer to that question. But the challenges.
Sorry.
No. Because it's very hard. Everything is very hard to predict at this point. And the challenges as a queer activist in low and middle income country. So I can just name 3 main challenges, like lack of collective support, lack of evidence, and lack of funding, obviously, right? So it's really hard to solve the third challenge, funding. It's really hard. We have to keep doing what we're doing for at least another 10 years. And after that, we hope that the environment would change. The lack of collective support and evidence is something I really want to emphasize all the time, because as I was saying before, we tend to forget how important it is to cultivate strong, united, what do we call it?
Like connections and communities.
Yeah, connections and communities.
Mutual support.
So for marginalized community, that's something we're lacking. So when it comes to state, the marginalized movement, civil rights movement, especially LGBTQ movement, feels very individual. So that is why, I think it is very important. And I don't think this is something that Australia, the audience, can learn from my experience. I think Australia, in terms of queer equality, is very progressive, doing good. I'm here to learn from it, but my experience is very much like that. As a queer movement activist, we never had a collective support from the academics, from the journalists, from the human rights defenders, from the feminists. It's really hard to fight in an environment that is constantly excluding you from the very important frameworks. For example, gender equality is one of the most important frameworks that queer people should be included, and so we can be included in the policy and our life can be better. But the gender concept itself is very binary, very exclusive of queer people across the region, particularly Asia, in Asian country, Central Asia. So to me, the redefinition of gender is very important. So that's how we can like progress, and redefining gender as more broad and inclusive way can just improve like most marginalized community very effective way.
As you can tell, I completely agree with you. You know, I'm, you know, with my body trying to redefine gender. No, thank you so much for that reflection. Absolutely. So that leads very, very nicely to really the bulk of what we wanted to talk about. And if we're not too behind on time, we'll open up for some questions. So let's talk about reimagining gender equality. It's a beautiful segue, Jack. Thank you. I found the phrase from the Beijing Declaration quote quite interesting, that it said, equal partners with men. And my question is, but equal to what? In a patriarchal world with Euro and US centrism up to this point, is that something we're really aiming for, or has the Trump administration now given us an opportunity to completely reimagine the aim of the game? Is the aim of the game equality with how men operate in a patriarchal world, or if not, then what does the playing field look like now in terms of gender, and what are we aiming for? I'll start with Kathy, but we're all going to chat about it.
The wording of Beijing is of its time, and
and it was revolutionary at the time.
time.
I remember it very well as being massive.
Yeah, but it's flawed, and I think there is an opportunity for, and there has been progress, I think, but there is an absolute need to advance thinking around gender inequality to a much more inclusive way of approaching gender inequality. And Jack's, really given a very clear example from your own experience of exclusion from, feminist movements, women's movements, and so forth. Has Trump given an opportunity? Look, and we'll hear a lot more about this through the day. The global health sector obviously needed to shake up, and not a shake up, a complete change. Is this the way to do it? Well, it's happened. And so I think we have to think about how we make the best of that. Noting
Forgive me for jumping in just because of time.
Yeah.
I think we all agree, yes.
Yes.
It's an earthquake and it's going to change. So
has changed.
How would we transform that gender equality lens to something for the next 30 years?
So I think this is where your point about not focusing only on legislative change, the sort of top-down instruments for bringing about gender equality, but increasing focus on the sideways connections and the bottom-up demand for change, and strengthening solidarity with communities. And that means all in communities. It's not about women trying to be, replicating some pretty flawed ways of being a man in the world, but for men as well, who most men don't aspire to be Donald Trump, to thinking about new ways of being together in solidarity with each other and being human. I think that it would be my desire that out of this moment we have more community to community connections. And I think the point about evidence is also really important, which I guess speaks to Mary's point about how the challenges of generating that when the funders and drivers of science are banning words hand over fist and making that very difficult to do.
Well, let's spring from that, because we sort of had a discussion point around that too. So regarding evidence, with the current information or disinformation ecosystem, it's no longer really enough for institutions to identify a problem and implement interventions and demonstrate results. So particularly for gender programs, how do we contend with this, which is almost certainly going to get worse as far as the disinformation environment, and broader issues? Meru.
Look, I think it's complicated, and I guess a lot of it is structural inequities. And I completely agree with Kathy and Jack and yourself around the binary idea of gender. I think we need to be more open. And when we look at the Beijing Declaration and words, we have to rethink how we talk about a lot of that. But I want to sort of think about the reimagining piece in terms of where we are and what we can do. And I like to sort of put this in 3 forms of reimagining. Is, I guess, thinking about who do we see as a leader and what makes a leader. There's very traditional norms around who is a leader. And in fact, there have been recent studies where nearly 50% of the world's population thinks that men make better leaders than women and transgender or LGBTQ people. So that's saying something, that people still think that men make better leaders. The second thing is to think about, I guess, who is valued? What is the value of unpaid labor, and how much is the gender pay gap? We know even in our own settings, Australia is at about a 26% gender pay gap. And so thinking about that and professional hierarchies, social and cultural norms that exist in the health sector that prevent equal gender parity in leadership is where I'm thinking. And I think the final one I like to think about is around inclusivity and intersectionality. And where is the role of leaders? And if I might just put some plug of numbers as well, in the UN, till date, there's been an 80-year history, there's been no female Secretary General. And when you think about the Australian sector, till date, from the 1980s, when the Chief Medical Officer position was created, there's only been 1 female Chief Medical Officer till date. So that gives us a lot to ponder and think about as well. So I'll pass it back to you on that.
Yeah, absolutely. Completely agree. And in healthcare and medicine, we've got a lot to answer for when it comes to diversity in leadership. Completely agree. And tragically, the latest UN Division for Women was headed by a male ambassador from Saudi Arabia, which was great. So, yeah, as a profession, yeah, I don't know what else to say about that. It's been extremely frustrating working in this system since the early 90s and not seeing enough of a change. So, Jack, you mentioned the real connection between rights or the rights discourse and individuals. And I thought that was spot on as being an impediment to sort of creating mutually supportive communities. Can you talk a little bit more about that? And in that, there's a quote that speaks to that a little bit, which is that equality seems to be imposed externally by institutions in the form of rights and protections, whereas freedom is a felt and shared experience created through our active doing. Therefore, freedom is claimed, it's actualized in practice. Is that similar to what you were alluding to with the rights and individuality?
I think so. So, like, a lot of the times, based on my experience, like, we experience collective, like, achievements, but many times the desired change, desired reform are not materialized due to a fragmentation of civil society. So I was in the civil society for so many years, and that's the biggest challenge in my country, in Mongolia, because we're still trying to collectively, move forward instead of using this individualistic approach. And this is particularly relevant for LGBTQ movement and LGBTQ activism, because obviously because of the social stigma and discrimination, a lot of traditional beliefs and norms are really preventing the other civil society movements, other groups to join us as a comrade. So like I hope like I'm talking in relation to what you asked.
Absolutely, 100%. And I'll finish up with Kathy perhaps on that theme. Just to finish it up, like rights and protections are connected with the seat of power. And so what do you see as being the main priorities at changing that for gender in the next 30 years?
Partly speaking to Mary's point about who is a leader and having a much more inclusive approach to who is a leader. In response to what Jack has talked about, yes, there does need to be a focus on things like legislation and top-down change, because it's all very well to try and claim freedom, but if your very being is criminalised, it puts you at grave risk of doing so. But I think it needs to be both top-down and bottom-up, and that's how social change has always happened. When you think of Treatment Action Campaign or the Landless Workers Movement or whatever it might be, it's always been demands from below meeting receptive allies in positions of power. And so everyone in this room is in a position of power. How do we use that in solidarity with people who have the most at stake in these really uncertain times in global health?
Thank you. I think that summed it up brilliantly. Thank you so much for your time and attention. And now this discussion is at an end.
Thank you so much, Danielle and panel. We'll just do a bit of a transition to the next theme. I'll just ask the next panelists to join me on stage, and I'll introduce myself because I'm the moderator of this session. Some planetary health. Will profits and politics be our demise? I'm Selina. Properly introduce myself. I'm the Executive Director of the Australian Global Health Alliance. My confluence of interest, not conflict of interest, is that I'm also a consulting editor at the Lancet. So really happy to present a report later today. Hi, Donald. Thanks for joining us. I'm very pleased to introduce. Hi. I'm just introducing you. I'm very pleased to introduce you, Donald. Dr. Donald Wilson is the Acting Dean of the College of Medicine, Nursing and Health Sciences at Fiji National University. He's a public health physician and has spent 12 years in Japan, where he did his postgraduate research in the area of occupational and environmental epidemiology. His current areas of research interest are in water-sensitive diseases and re-emerging chronic diseases, sexual reproductive health, non-communicable diseases, particularly its disease burden and the importance of policy responses. And then beside me is my friend and esteemed colleague, Professor Catherine Bowen. Thanks very much for joining us, Catherine. She's a leading internationally recognised expert on the science and policy of sustainability, particularly climate change, and a global health expert. That's all enough, but no, it's not enough. She works also she has a joint position at the Melbourne Climate Futures as Professor Environment, Climate and Global Health in the School of Population and Global Health, Faculty of Medicine, Dentistry and Health Sciences. So thank you to both of you for joining us today. We've got about, I think, 20, 25 minutes, and I think the moderator of the next session is just arriving. Right now, we are facing very big challenges, no more, I think, than has been internationally recognised in terms of the threat and sometimes say opportunity of climate change and health. But I'm going to give Catherine the very easy task of helping us understand, with all these changes that have been going on and with all of us looking at different parts of our world in global health, where are we at globally in terms of the global summary of climate change and health? And thanks for agreeing to do this.
Thank you, Selina. Thank you for the invitation to speak. And hello, Donald. Lovely to be sharing this virtual stage with you. Yeah, so I think I have a couple of minutes to talk about where are we in terms of climate change and global health internationally. I've got 3 points I'll talk to really to give us an update on that. The first one is around the climate change and human health community. And so one of my colleagues, Professor Chris Ebi from the University of Washington, she talks about 30 years ago, it was possible to fit all of the climate and health researchers into a phone box. And I assume that's probably 3, maybe 4 people. At that point, it would have been herself, Chris, Professor Tony McMichael, who many of you would know from his time at ANU, and also Professor Andy Haynes from the London School of Hygiene and Tropical Medicine. In the last 5, maybe 10 years, we've seen a massive expansion of researchers in climate change and human health. And so maybe we might now refer to a TARDIS, so a much, more, much larger vehicle to transport all these researchers in climate change and human health, which is wonderful in terms of the interest and how quickly it has really really linked up with people's research and interests, but it's also quite challenging. So I think that's what I've noticed in the last few years, in particular, with massive influx of the field. And this is challenging in many ways. It's challenging because there is already duplication of effort, which is really, given the scarce resources we have, when we see groups doing the same sort of stuff without acknowledging what's already occurred is really, really problematic. So it's oftentimes a lack of acknowledgement of the existing knowledge that has built up over, the 20 or 30 years that there has been that active community. I think partly that's due to the sense that there's a lot more funding in climate change and human health, and I would tend to say that that's actually not the case. There hasn't been such a great uptick of funding for climate and health, unfortunately. There's definitely been some newer players. So if we think about the World Bank, they've got a reasonably large investment in climate change and human health, as does the Asian Development Bank. The ADB in particular talks about themselves as being the climate bank by 2030. They want to be investing a certain amount of money into climate. But yeah, the funding is still very nascent and it's not nearly where it should be. In terms of our global community, of course, we are in very, very bleak situations. So adding on to what everyone already knows, I think that we all understand the US withdrawal from many international bodies and international commitments. I'll just remind everyone that the US has withdrawn from the Paris Agreement, and it's also withdrawn from the largest multilateral climate financing mechanism, which is the Green Climate Fund. So the GCF is the method by which the Global South countries will be provided with funding to support both adaptation and mitigation activities. The GCF pledges to collect $100 billion per year by 2020. It didn't actually reach that target, although some estimates from the OECD said it may have one of those years. The renewed commitment that was agreed to at last year's Conference of the Parties, the COP, was that there'd be $150 billion per year by 2025. So we're nowhere near that, and especially with the US withdrawal from the GCF, we're really in a critical situation at the moment. The WHO, has talked about climate change as the biggest risk to health in the last few years, and so given that announcement from the WHO leadership, we would expect to see a lot more action, but it really hasn't emerged. And we know that the IPCC, the Intergovernmental Panel on Climate Change, the 6th assessment report that was released a few years ago, estimated that between 3.3 to 3.6 billion people live in global hotspots of vulnerability to climate change. So laying out a few more bleak statistics for everyone. So, but in terms of the climate and health community and what's been going in a good direction, we have seen at the Conference of the Parties, for example, health become much more active in those international negotiations. So we had the first ever health day at the 2023 COP, which was fantastic to see. We had ministerial roundtables with about 70 health ministers present. You know, the previous record was 2. So that was really incredible, seeing the massive ramping up of interest from health ministers. So that's really positive. But the second point I'd note around, you know, where are we in terms of climate and health? I'd just remind everyone that really the way we look to addressing the health impacts of climate change is understanding that climate change won't necessarily bring anything new or particularly different. It will exacerbate current underlying issues that the health system is already dealing with. And we obviously need to take into account projections over time and how we'll see changes in rainfall and extreme weather and so on impacting our health status. But really what we're talking about is addressing the basic building blocks of the health system. And yes, it might sound dry, it's not particularly sexy, but it is about access to clean water and clean and safe drinking water. It's about making sure that we have food security globally. And we know if we look at the example of food security, there's still, the figure was 2.3 billion people have still faced moderate or severe food insecurity in 2023. And this has been stubbornly high for the previous 3 years. So basic issues around addressing our health system is one of the areas that we really have not, moved along as fast as we've needed to. And my final point really is around progress on climate change and health policies and planning. So the countries are at the moment developing what's called their Health National Adaptation Plan. So this is the way that the health sector is figuring out how do they adapt, how does it adapt to the impacts of climate change. And this feeds into the national level processes. It's called the National Adaptation Plan. And countries submit this to the UN's Climate Change Organisation. And they're supported to keep on track. And so there's a really great increase of countries who are actually developing their health national adaptation plans. We have the framework for a health national adaptation plan here too in Australia finally, which is fantastic to see, and kudos to the department to be working on that in the last couple of years. But what we've seen is they exist, those plans, but there has been insufficient support for implementation. And that's often where the health sector does fall down in terms of, well, how do we actually implement these? And in our example in Australia, we haven't seen the funding to back up that strategy and that plan in terms of implementation. And the HNAP is really, really important because it sets the direction for the Ministry of Health in terms of its climate activities. So without the HNAP and without its implementation, there's really not a lot of place for it to go. And then I'd just say that one other example of progress in terms of climate and health policies and planning, and it was good to see Lucas in the meeting earlier, is that DFAT now incorporates considerations of climate change in its health designs. And I've been fortunate to lead that contribution, and it's been fantastic to see how the Australian government has been leading the way in those bilateral commitments. We're the first country to be looking at how do we actually incorporate climate change considerations in the development of health designs for our partner countries. So I'll probably leave it there.
Thank you very much, Catherine. And thank you for really your clear communication. While it's bleak, I think it's really important for the rest of us to understand that it's not rocket science, that some things are actually surmountable. And I think communicating that clearly is really important for those of you in the audience who are perhaps not directly working on climate change and health, but know that you have to and want to. So the next question I have is for Donald. Donald, welcome and thank you so much for joining us. We really appreciate it, even though you probably can't see the audience here in the room or online. Firstly, do you have anything to add from your perspective to what Catherine just mentioned? But secondly, could you provide insights into the key developments and initiatives at the regional level, particularly, I know, with your involvement with the Oceania Planetary Health Forum?
Thanks, Selina. Just checking, can you hear me?
Very well, thank you.
Thank you. And Bulavinaka, and warm greetings to you and to Catherine and everyone listening. I think maybe, Selina, just correcting my introduction, I think that was an old bio. I'm currently the Associate Director of Research at the College of Medicine at FNU. But I'd really like to just thank you and thank the organizers for the great honor of being invited to share a few thoughts in this very important meeting. And I'd also like to acknowledge the indigenous owners and custodians of the land on which the meeting is happening today, and I pay my utmost respects to the elders of past, present, and future. And I think maybe to start off, and that was really great, Catherine, thank you for sharing those updates. For Fiji, when we had this, so we had the Oceania Planetary Health Forum in February. It was an opportunity, I think, also for many of us to reflect back. This year was exactly 30 years after the first Pacific Health Ministers meeting. The first Pacific Health Ministers meeting happened on the island of Yanuda in Fiji, and that was in March of 1995. And that was also where they signed the first Yanuda Island Declaration, which is also called the Healthy Islands Declaration. And if you've read, you'd probably recall that what was signed in 1995 was a 4-part declaration, and it reads, the healthy islands should be places where children are nurtured in body and mind, environments invite learning and leisure, where people work and age with dignity, and where ecological balance is a source of pride. So 20 years later, from 1995 to 2015, the 11th Health Ministers meeting convened again on Yanuda Island. And so the revised declaration added another clause, making it sort of a 5-part declaration. In addition to the 4, the last one was the ocean which sustains us is protected. And so I think for a lot of health professionals, this forum also helped us to understand why we as health professionals also need to see how important our ecosystems are. And I think it was such great wisdom. We need to really ask ourselves why even 30 years ago, our health ministers, these were health ministers, included ecological balance as a source of pride in the declaration. And 20 years later added the ocean, which sustains us, needs to be protected. And I think for us in the Pacific, what's happening is we are almost depending on information that is coming from outside of the region to be reminded of the importance of looking after our ecosystems. So from 1995 and after 2015, from the first one and after the 2015 meeting, was developed the Healthy Islands Monitoring Framework. The Healthy Islands Monitoring Framework has a big 48 indicators to try and monitor what was endorsed in the first first Pacific Health Ministers meeting. And the latest reports, which is a few years ago, have shown that the reporting is rather slow. And this is, I think, largely due to the unavailability of data that would inform the individual indicators in that framework. But there is also an indicator on ecological balance in this in this monitoring framework. And that is also slow. But I think one of the things I've personally learned from this Planetary Health Forum is the importance of sharing, particularly among health professionals, that while we look at human health, while we look at environmental health and maybe expand into the One Health sort of concept and look at animal health, it's also important that we understand how important when we look at things like climate change and understanding that our health indicators such as, we have typhoid, leptospirosis, dengue, we have research that has shown that a lot of the surges in these endemic diseases and infectious diseases that we have are very much linked to landslides, for example, flooding. And these are events that are very much linked to our ecosystems, and they affect the livelihoods of people who live downstream, and the fisheries are important. And if we don't link these to health, then we will continue to miss out on a lot of things. And you're probably aware of SPC, which is the Pacific Community. The Pacific Community which is also the secretariat of the Pacific Heads of Health, annual Pacific Heads of Health meetings, has also in the 2019 meeting raised the importance of the One Health and the planetary health concept. And as a result, one of the key focus areas of SPC is planetary health. And so in connection to that, we have at FNU, we in collaboration with a number of universities, I think some of you might have heard of the RISE program or project, Revitalizing Informal Settlements and Their Environments. And I think we're aware of the fact that a lot of drinking water in informal settlements is contaminated with fecal material. And with the sort of setup in informal settlements and the kind of places that they live in, predisposing them to very vulnerable to things like flooding and other natural disasters. The water rises and drops and dries again, and so there's a continuous circulation of fecal material in drinking water, and so there's always high prevalence of diarrheal disease. And I think a lot of you who work in informal settlements would also understand that. And just the lack of access and the informal arrangements that exist in informal settlements predisposes them to continue this continuing cycle. And so the RISE program is one of those that looks at nature-based solutions and looking across there's a program this program is based in Fiji and Indonesia, a randomized control trial, community-based, and looking at how communities in informal settlements, I think when we look at how best to maybe stop the mixing of drinking water and sewage water and things like that at a very basic level, that would help reduce the burden of disease. And there's another program, the WISH program, Watershed Interventions for Systems Health. This is based in indigenous communities of villages in Fiji, and looking at ecological watersheds and how it affects the health of people living in the downstream environments, because they've got higher incidences of water-related bacterial diseases. I mentioned typhoid and lepto that occur within the watersheds, and these have large tracts of cleared land and higher densities of livestock that access the watersheds and the waterways. So, the importance of looking at alterations in these watersheds and how they promote flooding and standing water can also accelerate mosquito-borne diseases like dengue transmission within these rural communities. So, it's these same sort of activities that increase the amounts of sediments and nutrients that enter the waterways, and therefore resulting in devastations of drinking sources of water. So that's taking on these planetary health approaches and really trying to get people who work in health and the stakeholders to understand how important it is that we continue when we are building and engaging with communities, that we also get them to recognize and realize the importance of looking after the ecosystems around them.
Thank you very much, Donald.
Just to sort of add or end, Selina. Yeah. Sorry, that we established, we launched our Pacific Planetary Health Research Center at that forum. And I'll just close with this about the forum, us recognizing, we had a gentleman who came and spoke about culture and the connection of culture to the kind of practices that we have. And we really very pleasantly recognized that we are forgetting the importance of our indigenous knowledges. And I think when we're engaging with communities, and this gentleman who came and spoke to us, and I was just asking him, what is it like when you're engaging with communities? Are the elders of communities teaching the young people enough about how they look after the lands, their people, their animals, and their resources. And his answer was, it's really, it's sad because a lot of that teaching is no longer happening. And one of the very important things I think we recognized from that meeting is just the importance of people going back to indigenous knowledges and incorporating those into how we look after our ecosystems. I'll end there for now, Selina. Thank you.
Thank you so much, Donald. I apologize for the bio warp. You didn't see me sink into the floor then, but particularly thank you for the wisdom and the sharing of those two fabulous programs, Rise and Wish, which is a very good example of when investment in research comes to fruition, and also for emphasizing the role of First Nations communities and actually the right and the historical right in this field. So I'm going to segue to a very different rhythm now and ask Catherine, back to the title of this session, how do political dynamics, we are about to have an election here in this country, and corporate interests pose both risks and opportunities in advancing this field, whether it's planetary health or calling it climate change and health?
Thank you, Selina. And having a look through all the headings of your panels, it's quite an intense collection of discussions. So I'm hoping that there's a good reward at the end of the day for everyone, and also time to debrief really seriously on these all of these really important topics that we're discussing today. So what we often hear is that we know all the science when it comes to climate change. The one thing we are missing is political will. So that's been something that's repeated regularly over the last 20 years or so. And yeah, it's something I think, as many of us in the room are researchers, research clinicians, you know, I think that we need to question what our role is. What is our role in terms of advocating for action on climate change and human health in particular? And how do we, you know, I remember Tony McMichael actually said that if you're working in public health, you are by definition an advocate. It's not a term to be shying away from. It's something to be really proud of. And so I think that the political dynamics play an important role in terms of the work that we do, the work that we allow ourselves to do. But also, you know, it does challenge us to think about the ways we work. And given all of the uncertainty in the global political environment, the uncertainty here in Australia, I know that there are tabs on how the direction of the direction of the election outcome, but really it's too close to call, so we can't be assuming one way or the other at the moment. And so I think that it's important for us to be much more active in the debate, which doesn't not always come naturally to all of us, and perhaps that's fine, and actually that totally is fine. One thing we're doing at Melbourne Climate Futures is a climate action tracker. So we're looking at all of the election commitments across all issues climate related, whether it's litigation, whether it's you know, the EPA, whatever it might be, the Environment Protection Agency, but also the climate and health commitments. So we're trying to get a sense of, well, what sort of commitments are the parties or the candidates declaring at the moment, and then sharing that as something that's open to the public and having that as a dynamic feature of our website, so that people can come in and look to us as a university. We're a public good. We need to show ourselves as that. We need to be presenting the information and really allowing a much closer scrutiny of you know, the sorts of information that we do know. So that was just one example, I think, of where we can really step into the debate as researchers. I think also there's a really interesting climate scientist in the US called Catherine Hayhoe. She is a hardcore climate modeler, climate scientist, but she's also a evangelical Christian. And so it's really, really interesting combination I'm not an evangelical, I can't even say it, evangelical Christian, but, and I won't say but, and I really appreciate what she has to say. She's really got a power in terms of the way she communicates. And she talks about 3 ways to push through the politics of all of this. She talks about connecting with the head. So obviously we need to be sharing the information, sharing the statistics, making sure that it's evidence-driven. That's the head component. And then she talks about the heart. And I think this is where something we just don't do as a global health community. We don't think about what do people love? What do people love doing? Who do people love? Their family, friends, and so on. What are the places people love? And this is the way that we can connect with others on issues around climate change. We can see where people are and connect with them in terms of the way that we all love something in the world. How do we potentially use that as a mechanism to connect and move beyond this binary situation where we are at in terms of either climate action or climate denial? And then the third, she added this in the last few years, the third area that she talks about is the hands. So it's not just enough bringing the data, bringing the evidence, talking about the ways you can change the world because of the things you love and how they'll be affected by climate change, but actually the action, what you can do. So it's those 3 components, the head, the heart, and the hands, in terms of seeing everyone's role in relation to responding to the threats that we all face in relation to climate change. And I think it's that's really important at the moment. We really don't have a lot of say what's happening in the US. We don't really have a lot of say what's going to happen here either, other than casting our vote, which is very, very important. But those other ways we can connect with our communities are really, I think, vital for us and give us all hope as well. And as an example for me, I think that it's important to be clear on the values that we all hold and the values that we place on the work that we do, and being really clear on what keeps us going, and partner with the groups and the individuals who respect those values. We all have different values, absolutely. That's of course the case. But it's about respecting those different values. And as one example from my experience is a partnership we have with the Pacific Climate Change Centre, which is led by an incredible woman, Ofa Kaisami. She heads up the Pacific Climate Change Centre, when we've developed a partnership that's based on respect, trust and integrity with the work that we do. And we're continuing our work on climate and health with our partnership with the Pacific Climate Change Centre, regardless of what's happening in the political landscape. And so for me, that's really, really, really important to as a way of keeping sane in this environment at the moment. But also, you know, knowing that we're working with an organisation that has the same values and the same determination. So that they would be a few reflections on how we connect in the current political environment.
Thank you so much. Really appreciated. I'm just remembering words of Helen Clark, former Prime Minister of New Zealand, on the notion of values, because I asked her, how do you work with groups or countries with very different values? And she said, it's easy. We all have different values, but we always have shared interests. And on that point, your point in terms of the heart and, you know, having a face and what matters to you, it's something that in the global health community, the public health community, we've always known and learnt through the HIV movement that, you know, people living with HIV/AIDS were front and foremost of the movement, and that meshing science and actually hand you know, the donations was really important. So I really love that, and thank you for that message. I'm just going to do a quick time check that our third moderator is here. Great. And Donald, I'm going to ask the final question to you in terms of what practical steps or shifts, actions do you think need to be taken in your perspective to have meaningful change? We've heard from Catherine just then. Thank you. Over to you.
Thanks, Selina. Maybe if I may just start off by saying, when I read the theme of the session, "Dangerous Liaisons in Planetary Health," it occurred to me that that was the name of a movie that came out in the late 1980s. Very highly charged movie. I think it was John Malkovich, Glenn Close, Michelle Pfeiffer, and just a really star lineup. And so if we imagine them 40 years ago, and it was a story of two amorous lovers who turned rivals and who amuse themselves by, ruining others, and who ultimately destroy each other. And so I was thinking, maybe not directly addressing your last question, but I think the term "dangerous liaisons" is appropriate when we're talking about politics and profits. And as far as planetary health is concerned, I thought I'd highlight an issue that came up during our recent Oceania Planetary Health Forum that was held in Fiji. Before I maybe close off with a few thoughts. Sorry, Selina, I'm seeing red bars, so I'll turn my video off just so that I keep my bandwidth. Please just advise, can you still hear me? Can you still hear me?
Yes, can still hear you.
Okay. All right, thank you. Yeah, so at the Oceania Planetary Health Forum, an issue that came up was on deep seabed mining, or DSM, and particularly focused on what's happening in the Pacific Island countries and territories. And we had the former president of Kiribati, Mr. Amate Tong, as the first keynote speaker, and Fiji's Minister for Lands as the chief guest. And President Tong made some reference to seabed mining in Kiribati. I'm not an oceanologist, I'm not a mineralogist, but there's quite a bit of information that's carried by the websites of SPREP, the South Pacific Regional Environment Program, Fiji's Ministry of Information. And, we know that while deep seabed mining promises, access to valuable minerals, there's also significant risk to planetary health that includes like damage to ecosystems, unique ecosystems, and disruption in ocean processes, and so there needs to be a cautious and precautionary approach. For Fiji, at the last ocean conference that was held in Portugal, the former Prime Minister of Fiji supported the moratorium on deep seabed mining, and that was in 2022. And he also called upon, fellow Forum Island states to support this 10-year moratorium on seabed mining from 2020 to 2030, just to allow for a decade of proper scientific research of our economic zones and our territorial waters, and to engage in partnerships. At this point, and again, this is on information that's broadly available, I think there are a few countries like Nauru, Tonga, Kiribati, and they've expressed the support for deep sea mining, and some have even entered into exploration contracts. So obviously for us in the Pacific, and as developing states in the Pacific, there's obviously need for resources. I mean, there's need for money everywhere in the world, but in countries where climate change and rising sea level is a real thing, there's need for resources now. There's need for resources urgently. And so where there is opportunity for resources via natural resources that belong to the countries, I think countries choose to look at those economic opportunities. And Fiji, I think, and a few other countries continue to show their concerns about these environmental impacts of deep sea mining, and a lot of biodiversity loss and things like that happening, including some of our CSOs. But I think going forward, and what Fiji, I think, continues to uphold the moratorium on deep sea mining until we've got this comprehensive scientific assessment. And also Fiji is probably, I think, is looking at the exploration licenses with outside countries. So just to say that I think, if, going forward, when we're looking at natural resources and opportunities for economic or revenue locally with what we have, the primary concern really is the potential for irreversible damage happening to our fragile ecosystems. And I think that's especially when the ecosystems are home to unique and undiscovered species. So countries, there's obviously the opportunities for growth, but I'll go back to the point that I raised earlier. I think we should not forget that each country has its own indigenous knowledges that we need to, when we're engaging with communities, that we recognize that they also have their own wisdom and knowledges that we need to include when we're building policy and, for government or at the national level. I'll stop there. Thank you. Thank you, Selina.
So many thanks, Donald. And you definitely got the brief. I was waiting to see who could respond to the title of this this provocative title of this session. With that, I want to thank you and Catherine for your wisdom and your generosity in sharing your time. I know how busy you both are. I know how important both of your work is right now to the field in which you're engaging. And it's really important that you are here with us today. And I just want to ask the audience here to join me in thanking you really sincerely. Thank you.
Ninaka, thank you.
Many thanks. So I'm going to now hand over to the moderator of the third panel. There will be a break with refreshments after this conversation. And I'm really honoured and pleased to introduce Reverend Tim Costello, who many of you already know. He's one of Australia's most respected community leaders and a sought-after voice on social justice, hi Tim, issues, leadership and ethics. He's the Executive Director of MICA Australia. He was the Chief Executive Officer of World Vision Australia. He has so many accolades, but I just want to say this because I've rarely gotten the opportunity to introduce in my capacity. He was, in 2026, he was Victoria's Australian of the Year. In 2005, he was an Officer of the Order of Australia, and both Victorian of the Year, and in 1997 was named as one of Australia's 100 National Living Treasures. So thank you so much, Tim, for joining us, and I'm going to leave it to you to introduce the panel.
Thank you so much for that introduction. It was pretty much as I wrote it, really. So the afternoon session, which is often a bit of a sedative session, but let me introduce our panel on the Zoom. Arun Jegan works with MSF as their Humanitarian Affairs Lead. He's an experienced head of mission and emergency coordinator and has worked in occupied Palestinian territories, Yemen, Syria, Venezuela, Bangladesh. Prior to joining MSF, he worked in Afghanistan, Sri Lanka, Iraq, Jordan, Lebanon and Turkey in senior management positions for other international NGOs over his 15-year career. While he specialises in humanitarian crisis coordination during public health emergencies, he has also been exploring relational approaches to advocacy, using co-design, creative practice and community engagement through the Creative Advocacy Partnership. So would you welcome Arun? Dr. Rachel Coughlin has over 20 years of experience in public health, humanitarian response and clinical practice. She brings expertise in palliative and end-of-life care, ageing and frailty, disability, rehabilitation, and non-communicable diseases. Rachel has worked across humanitarian and aid agencies and where am I up to here? with donor organisations and academic institutions. She is a global leader on qualitative research and advocacy concerning palliative care in humanitarian settings. Her current research focuses on palliative care for people with serious illness or injury during armed conflict. In 2023, Rachel was awarded a Fulbright Professional Scholarship Award for not-for-profit leadership, spending time at the Centre for Humanitarian Health, that's the Johns Hopkins University, to foster dialogue and strengthen policy and practice on palliative care amongst humanitarian agencies. Rachel's work is underpinned by a commitment to understanding the interplay of context, culture, society, and politics on experiences of ageing, illness, dying, and bereavement, and to exploring the intersections of health and social approaches to caring. Her research interests span medical anthropology, experience-based co-design, and narrative inquiry in disability, ageing, and palliative care. Rachel is a storyteller who focuses on amplifying the voices and wisdom of those affected by illness, disability, or frailty. Rachel's a practicing physiotherapist in specialist palliative care, neurology, oncology, and rehabilitation. She has a Master of Public Health in the international stream and a PhD from the Centre for Humanitarian Leadership at Deakin. She holds board director positions with Asia Pacific Hospice and Palliative Care Network and Palliative Care Australia. Gosh, how did I get through all that?
Who submitted those bios?
If I'd read them first, it would have been easier, so apologies. Welcome to both of you, and the theme of this session is really about humanitarian work and empathy. And I have been doing some touring of Australia for the last 2 weeks, really, which I'll talk about in the next session, really around our campaign, A Safer World for All, and quoting Elon Musk. Elon Musk on Joe Rogan said, "The fundamental weakness of Western civilization is empathy." He said empathy has been weaponized. This man worth $400 billion, the richest man in the world, has smashed USAID, some 54 billion pulled out. I would have thought the fundamental strength of Western civilization is empathy. Let me, because you're here first, Rachel, just go to this question of humanitarian work and empathy in your experience.
Right.
Thanks, Tim. You're gone off the cuff. You always did go off the cuff of your question.
Sorry, I do have a question here. That's.
I think I'll start by saying it's really lovely to be here with you. My personal link, I guess, to this conversation around empathy and storytelling is that my very first job in the development and humanitarian space was at World Vision Australia when you were at the helm, and probably learnt an extraordinary amount from you on the art of storytelling that I try to put into practice now. I think in response to that, I would take empathy one step further and say that we should be talking about reclaiming compassion in humanitarian crises. Empathy is the feeling that allows us to bear witness and to walk in the shoes of somebody who is suffering. But compassion takes it one step further. And as Brendan said at the beginning of today's session, we need to have courage. I think compassion is the thing that gives us the courage and the strength to act. So I'd say let's talk about compassion. Take that back to Elon Musk. Maybe if I can come to how I think we need to reclaim that empathy and around storytelling. And I'm going to focus my contributions this afternoon on Gaza. It's a context that I have a deep personal connection to. It's where I did my PhD, and I maintain many friends and colleagues there, particularly healthcare workers that I'm in constant contact with. And I think that in the current dominant narratives that are used to drive public and policy responses, the truthful storytelling of real experience is something that's become quite lost. On a visit to Gaza in 2020, I made a pledge to my colleagues there that I would focus on sharing their voices and amplifying their voices to the world. And in early November 2023,
our colleague, Dr. Hammam Allo, who was one of Gaza's handful of kidney specialists, there are now none left, he was killed by a bomb strike on his home at the age of 36. And he had messaged me via WhatsApp that morning before he was killed and said, "Your shouting means a lot to us. Please keep it up." And so I resolved to do so. And for the last 18 months, I've been contributing particularly to Crikey, a series of stories that have focused on trying to reclaim empathy in the Gaza crisis and focused on storytelling and sharing the voices of Palestinians. I want to share one of those Crikey articles or some parts of that, and this one was written in November 2023. Mahmoud, who is a Palestinian friend and a professor of Arabic language, writes, "It's not only bombs and brutality we are subjected to, but sheer demonisation and blame. The second is even worse." My good friend Ola, a Palestinian paediatrician, asks, "What else can we show to prove we are being killed with no mercy?" I wrote at that time, this week at the National Press Club in Canberra, the UN Special Rapporteur for the Occupied Palestinian Territory, Francesca Albanese, asked us to rehumanise the discourse. Behind every dreadful bloody truth is a person with a narrative, a past and future dreams, dashed or severed as they may be. I just need some water, sorry. And I wrote on. Among the missing, displaced and dead are accountants and engineers, physiotherapists and school teachers, lawyers and YouTubers, journalists and vets, clergy and poets, bread makers and street cleaners and beach caretakers. A taxi driver friend, Ahmed, displaced and living in a minuscule single room with 10 others, writes, "We are dying here," and then sends an image of his smiling daughter with the words, "She wishes us to stay well and in peace." In these stories, we must search for a piece of ourselves, tell not only horrors, but personhood, speak their names at the dinner table with friends. And so that's what I resolved to do. Last week, I learned that my taxi driver friend, Ahmed, who had driven me from hospital to hospital all around the Gaza Strip in 2020, was killed along with his 3-year-old daughter and his wife. So I choose to write, to play a very small part in filling cavernous gaps in reporting and cavernous gaps in empathy and compassion. Real human experience is not something that should be dismissed or made political or ideological. There are also expressions of obligation. Every single time I receive a ping of a WhatsApp message from a friend or colleague in Gaza, something wells up inside me and I feel compelled to write as a form of justice speaking. And there are also expressions of solidarity, expressions that show that some of us stayed and some of us listened and some of us cared. Even if they die, they know at least one person did care. And there's stories about combating dehumanisation and a lack of empathy and the invisibility of real people, all with stories and names and aspirations and dreams. Can I take a couple more minutes and read a quote from Mourid Barghouti's book, which was published in 2011, called "I was born here, I was born there, I was born here," because it very much speaks to this idea of centering the Palestinian narrative and reclaiming empathy. "The cruelest degree of exile is invisibility, being forbidden to tell one's story for oneself. We, the Palestinian people, are narrated by our enemies in keeping with their presence and our absence. They label us as it suits them. The weaker party in any conflict is allowed to scream, allowed to complain, allowed to weep, but never allowed to tell his own story. The conflict over the land becomes the conflict over the story, and little by little, the weak discovers that his enemy will not allow himself to be wronged. The enemy permits him only to be in the wrong, defective and deserving of pain because he has brought that pain upon himself through his defects and his faults. It is not his enemy's doing. This is the cruelest form of injustice, and injustice is a form of exile. Just as stereotyping is exile and misunderstanding is exile, in this sense, the entire Palestinian people is exiled through the absence of its story.
Thank you so much. That was very moving and showing great empathy. Let me go to you, Arun. Given your frontline experience, what are the most pressing humanitarian challenges you're currently facing? And how do you see the nature of humanitarian work evolving in response to global crises, particularly in conflict and climate-affected regions?
Hello there. Hi, Tim. Hi, Rachel. Very nice to meet you on here and very privileged to be on this panel with you both there. So, good question. I have to say that the biggest challenge right now is not just from what the needs are, but also this broken system that has just happened because the US has just pulled out, what is it now? Was it $43 billion from the global humanitarian architecture? Now, that's huge, right? Because if we're looking at it right now, last year there was a $32 billion shortfall already. And so this pulling away this much amount from the humanitarian architecture is actually quite existential for us at this present moment. It's close to 40% of the entire humanitarian ODA budget of the globe. So the best way I used to describe this is if I asked each and every one of you to lose 40% of your weight, you simply can't do it. It's too difficult, right? It's existential at this point. You will cease to exist. So the humanitarian aid system as it stands will cease to exist in the way it is. Some UN agencies have 40% of their funding been taken away. So we have to rethink now the way that we have been delivering aid. And that's going to be a big challenge for us right now. So that system, as we've talked about, is no longer existing. It will no longer exist in the future. We're also seeing that rising migration is going to become a really big part of the needs in the future. So we've got about 110 million displaced already. Now, if you think about the conflicts that have been going on, this increasing political instability that's happening, as well as climate change, that might increase in the future as well. I think the escalating health crisis associated with climate change and weather changing patterns and also poor medical practices that have just been going on for many years are another real big issue for us. And I want to particularly highlight antimicrobial resistance because that's something that we're currently dealing with. Is about 4 million people a year dying from that. And we expect that to raise to 10 million people by 2050. And so that's a really big thing. So about 1.14 million people who are directly die from drug-resistant infections is a big amount. In the hospitals and the war zones that I've worked and visited in, I've seen that cost firsthand. In Iraq in 2022, over 80% of injured patients suffered from multi-drug resistant bone infections. In Gaza, Yemen, 60% of injured patients suffered from multi-drug resistant bone infections as well. But it's not just the wounded. Newborns and mothers also face treatment failures that should never happen. We're also starting to see disease patterns change as well in climate change affected countries. And if we look at it from a macro point of view, last year alone, there were 25 countries affected by cholera. That's a pandemic. That's a huge amount of people. So we're seeing the 7th cholera pandemic kind of unfold in front of our very eyes. We're also seeing changing disease patterns because of climate, dengue and malaria, because mosquitoes are now being present in areas that weren't present before because of the changing climate. Really seeing that in India and Bangladesh. I think it was 2 years ago, the dengue season was one of the highest deaths and hospitalizations that we've seen in those countries. So those are some really big challenges that we're facing. To speak to what Rachel was talking about, conflict and international humanitarian law. The breakdown of that is also another big issue. We're seeing international humanitarian law in disarray. It's very difficult for NGOs, for humanitarian workers, for civilians to afford any protection in this new environment, which has seen Israel commit heinous acts of crimes against humanity or alleged crimes against humanity, and no real repercussion being placed on them. You've seen the same in Sudan. You're seeing similar things in Ukraine. So that breakdown in IHL is also going to contribute to a big challenge that humanitarians will face and civilians will face as well. Yeah, and then look, stacked up on against all of this is climate change, and climate change, and that's just intensifying all these risks that we're seeing, and it's playing out in real time. And later on, I can give you a few examples of where we've seen that translate directly into a public health crisis. But for now, these are the main challenges that we see.
Thank you. So today with tariffs, we've effectively seen America withdraw from the WTO, international trade rules. Earlier, it was announced withdrawing from Paris, withdrawing from WHO, not believing in medical science. It feels like a world that's gone crazy. That's on top of USAID being smashed. If I'm honest, I'm in great grief. I am trying to not allow my grief go to despair, because despair is a dead end. It cuts the nerve of acting. A question to both of you: given a world that seems unhinged, what gives you hope for the future of humanitarian work? What opportunities do you see to rebuild or strengthen global solidarity? We'll go to you, Rachel.
Thanks, Tim. It's incredibly hard to be hopeful right now, particularly when you wake up and follow the daily news in Palestine. And it's particularly difficult to feel hopeful about the responses of governments and powerful vested interests and institutions, and that includes many of our own health and medical care institutions that we belong to. I focus on storytelling. I honestly don't know if that will make any difference, but it's a small attempt to try and reclaim that compassion. But I think for me, the opportunities to strengthen global solidarity lie in the enormous groundswell of actions that we see being taken by individuals, not in our institutions, but by individuals, perhaps not being nurtured in the way that Jack had called them to do. And I think that groundswell of actions is spurred by the compassion and by the endurance and the steadfastness of Palestinians themselves. Our healthcare colleagues on the ground have not for a single day stopped to turn up to work and to care and to treat their patients and to hold the hands of the dying. And that's despite enormous grief, enormous loss, and enormous personal risk. Earlier this year, UN human rights experts wrote that the heroic actions of Palestinian medical colleagues in Gaza teach us what it means to have taken the medical oath. So we draw strength and compassion and action from them. I want to share maybe two specific examples of this groundswell of global solidarity that does give me hope. And the first example is in the growing global mobilisation of healthcare workers that emerged at the beginning of the current crisis in Palestine. And they advocate through a whole range of public vigils, through rallies, through social media outlets, and through trying to tap into mainstream media for an immediate end to the violence, for upholding international human rights and humanitarian law, including the right to health. And the majority of people in that movement are compelled to act out of a shared sense of vocation and duty and compassion. And there's a number of examples from Healthcare Workers for Palestine, a group called Gaza Medic Voices that I'm involved with that does focus on amplifying the Palestinian voice, and Healthcare Workers Watch for Palestine that has its mandate to document atrocities against healthcare workers and institutions. The second one is an example from a very personal recent experience. 3 weeks ago, I jumped very quickly on a plane to the Middle East to accompany a Palestinian friend named Dalal, who had just evacuated Gaza to accompany her on her onward travel to Australia. She'd been granted a visa to Australia to spend time with family here some months prior, and she was finally able to leave. She is blind from birth, and she needed hands-on support to make that journey. And she was given not much more than 24 hours notice to decide to leave Gaza, her home, possibly forever. And I was given not much more than 24 hours notice after that to get on a plane and go and meet her. And my last minute expensive flight was paid for through the generosity of friends and a number of strangers that I've never met who felt compelled to support once they had heard Dalal's story. And when I met her, she said that the Australian ambassador to Jordan had said to her in Jordan, "Welcome to Australia," as the Australian team gave her some fresh socks and a new wheelie bag. When we got to the customs official in the Australian airport, the customs official beamed and said, "Welcome to Australia," as Dalal declared it was the fastest and kindest border control she'd ever been through. At the airport, we were greeted by volunteers who neither of us had ever met, who came in droves to support her as soon as I had alerted the organisation Palestinian Australia Relief and Action. And if you don't know them, look them up and donate because they're wonderful. Dalal was gifted a gift pack of fresh towels and fresh toiletries and pyjamas and the obligatory packet of Tim Tams. Someone bought her a phone SIM card. Several people have dropped off Palestinian food and picked her up and taken her to iftar dinners during Ramadan. Someone else has bought her a new laptop, complete with software to support her with her disability. Someone else is setting up a bank account. Doctors and dentists are providing pro bono medical support before she is set up in a system properly here. That support from individuals has been so overwhelming and so quick to come that we have even had to ask for that care to just pause as Dalal, starts on her very long journey to process her grief and her trauma and her own story, both past and what is next to come. So it's been absolutely beautiful.
Well, Dalal is a story of hope. Arun, hope.
Hope. Do I have any? That's a good question. Look, I think Rachel really gave a great example of how communities help communities. And I think if we're just looking to people in power and institutions for that hope to deliver, we are seeing in front of us that system being broken. And I don't think we can really trust the institutions and people in power to deliver that. Time and again, that has failed us. And I think, the tendency of the past 2 decades has been for the humanitarian aid system to take on every ailment that besets the planet. And it has brought some good, but it has also weakened the capacity of the community to deliver some real impact on the most severe conflicts and crises. We have accumulated so many roles in standard setting, in coordination, in funding, and implementation. We've become an almost immovable object, immune to change, and sometimes the preserver of a status quo or dependency. Now, I think the question that we should be asking ourselves is an opportunity here is, should the humanitarian community and the system be providing welfare for all, or should we revert to a more limited set of objectives that really ensure access to essential services in the most acute and severe conflicts and crises? Should we be a system, or should we even be a system? Should we even have these strands of nutrition, health? And, if you look at the Bangladesh refugee camps, that's 1.2 million people that are living behind a barbed wire fence. But it's humanitarian government, basically, that is running the show there. You've got the health sector, the nutrition sector, the protection sector, all the different kind of sectors running services for 1.2 million people. The aid industry was never supposed to do that. The humanitarian community was never supposed to run a government, basically, for refugee camps. So I think we should, with the system kind of going to be broken anyway because there's not enough funds, should we start developing more plug and play kinds of models of interlocking national and interlocking local and international kind of initiatives? I think that's an interesting opportunity for us to now think about, because that gives us me hope for having a bit more agility and a bit more targeted kind of relief. I think if I go back to the macro now and think about reclaiming empathy and what gives me hope there, If we look at the world right now, refugees being locked up, aid budgets being reduced, countries looking for even bigger market shares in their wealth and not willing to share to the rest of the world, corporations becoming increasingly looked at to fill in gaps. It does feel like global solidarity is dying in one sense. And I really think we can be mistaken to think that human nature wants this reality. But as Rachel just talked about below, I don't think so. I don't think humans actually want that. And I don't know if you ever read Rutger Bregman's Human Kindness. It's a real fascinating book. It kind of relooks at historical events and sees the power of people and how people have often been doing good things even while horrible atrocities have been happening around them. If I take you back to the Bangladesh refugee camps, we often talk about this community as being dependent on foreign aid, and to majority sense, that is true. But if I just look a little bit deeper into that narrative, what do we say? We keep saying that this community is living on $12 a month for food. And that's what the UN is giving. That's what the WFP is giving. So they've been living on $12 a month, and the US has pulled their funding. So now it's $6 a month. Let's interrogate that for a second. No one on this planet is living on $12 a month for food. They're assisted by that $12 a month, but they're also looking for other ways. Communities are helping communities survive through this time. So I think what gives me hope is this reckoning moment for us to start looking and supporting communities directly, maybe not through the institutional ways that we have been doing in the past. Those will be broken in the future. So I think that gives me a little bit of hope there. And I think if I think about this sympathy, this empathy, reclaiming empathy, it's important for us not to fall into the trap of the 90s way of doing charity, the 90s way of doing humanitarian aid, which was, little brown and black babies there with flies around them, and us an outpouring of grief and emotion and sending money there, and then that it kind of stops at that. I think we need to start talking about empathy as a way to connect with one another, to build relationships with one another, and has to go beyond just donating money, I think. So that's a little bit what I think is going to help. How do we get there? Well, I think the more multicultural society that Australia becomes, some of these incredible statistics that I see, I think they're saying 50% of Sydney-siders have either immigrants or were born to immigrants' parents. I think more connections with people from different backgrounds and all of them being active members of civil society is a real opportunity for humanitarians, the world, and the NGO community to see where we can actually, where we're preserving the status quo or where we're looking to shift harmful practices and narratives about people. So that gives me hope.
Thank you. That's wonderful. It is true that the sort of values in this room, internationalist, universal, humanitarian, without us necessarily noticing, suddenly had a great reversal. Populism, polarization, post-truth, and it's just swept us very quickly. So a reset has been forced on us. I think some of the things you put in about plug and play, and we're not trying to do everything as we have in the past, is something I can take hope from. I think our time's up, and thank you so much, Rachel and Arun. Would you thank them?
Thank you so much, Tim and panel, for all your time. Arun, thank you so much for joining us. We hope to host you in the future here. So for the people in the room, there are refreshments at the back. We're going to take a break of about 10 to 13 minutes. Head for the bathroom. Women can use whichever bathroom up there. I know there's at least 3. And there's some refreshments up the back, but please, please come back for the rest of the afternoon, which is only 1 hour. We will be adding on the hope that I feel that this panel has already given us, even though it didn't start off that way in terms of the narrative. And for your knowledge, if you haven't noticed, we have a very special event in addition to the Lancet Commission launch in the next session. But after a very short reception, we have Professor Shea Mbimbala's book launch the inaugural Melbourne book launch of A Foreign Gaze, and we'll be in conversation from about 5:30 onwards with some other people who'll be joining us. So go ahead and have a drink and whatever snacks the wonderful team have arranged for you, and look forward to seeing you in about 10 to 13 minutes. Don't worry, we can work around it if we have to. We can put Tim after. Yes? Yeah. Yeah? Okay, great. Thank you. Welcome back. I'm really pleased to introduce my co-chair for this final session, and it's Julia Silveri, who's a final year medical student from Monash University, and also she's chair of the AMSA Global Health, the Australian Medical Students Association Global Health. It's the community for our future in many ways, and really honoured to be able to share this space with you, Julia. So I'm going to hand over to your expert hands for the next little while. Thank you.
Thanks so much, Selina. Thank you for having me here to represent the medical students. I'll be introducing the lovely panelists today, and then I'll pass back over to Selina to convene the rest of the session. So our first panelist is Barbara Roth, who's a Principal Manager for Medicines Access at the Medicines Development for Global Health. Our second panelist joining us online is Associate Professor Misha Coleman, who's a Director of Government Relations and Communications at the Australian Centre for the Prevention of Cervical Cancer. Our third panellist, we have Associate Professor Pete Lambert, who's a Pharmaceutical Science and Program Director at Monash Sustainable Development Institute. We also have the return of Reverend Tim Costello, who's the Director of Ethical Voice and the Executive Director of MICA Australia. I'll pass back to Selina to convene the rest of the session.
So we'll start. This session is looking at, well, the last session was looking at the challenges we have in the world today. This session is something hopefully a lot more hopeful, but I think very exciting, which is looking at a snapshot of some of the most I think inspirational and hopeful innovations and efforts from Australian science and global health. We want to start with Barbara Roth, and I'm just going to hand over the lectern to Barbara.
Hello, everyone, and thank you for having me here. I'm here on behalf of Medicines Development for Global Health. MDGH is actually quite a young company based in Melbourne, not-for-profit pharmaceutical company, which often raise some eyebrows whenever we present it that way. And I'm hoping to explain a little bit more what we do. We have a very specific mission. We develop and deliver medicine for neglected diseases that usually the commercial market has largely ignored. We have been actually a proud member of the Australian Global Health Alliance, and I really thank you for all your work in Australia, but also beyond. When I first joined the company in 2019, I was really struggling with saying medicine development for global health. I felt that it was really a mouthful. Maybe it's a little bit linked to my French accent and my French background, I don't know, but it was a bit difficult for me to say it. And the more I think about it, the more I find that it is actually exactly what we do. It's said in very simple terms, so it's not very fancy, it's not very sexy, but it's what we do. And I will start, I was trying to find an easy link for you to remember what MDGH is about. And I will start with, M for medicine, but I will have a case study which is on moxidectin. And then we will discuss a little bit more about the work that we really do. And then finally, what is really the impact that we are trying to have. Moxidectin is actually our lead product, and it's the first actually new treatment to treat river blindness. And for those of you who may have maybe passed by the WHO office in Geneva, you may have seen this statue on the left of the screen of that elderly man being guided by a young boy. And this is really a powerful image, actually, of the vision loss that is associated with river blindness. River blindness is a parasitic disease. Mainly 99% of the burden is actually in sub-Saharan Africa. And it causes severe itching and disfiguring skin condition, and sometimes evolve into blindness. Also, less and less so, because the community has been setting up a number of donation programs. One of them is ivermectin, which was distributed to many population living in endemic environment. And they receive those drugs for 10, 15 years, 20 years for some of them. Unfortunately, the disease continues to be transmitted, and some area actually are in need of an alternative treatment. And moxidectin is now the new alternative treatment. And I wanted to tell you a little bit of the story, because we are not for profit, but we are still a pharma company. We joined the company, or we joined the journey in 2014 when the pharmaceutical partner involved in that project with the WHO TDR department decided to pull out. We came in, worked collaboratively with many different stakeholders, and consolidated the dossier. We're successful in getting a US FDA approval. That was quite strategic, because that was an opportunity for us to raise funding and then to pay back some of the impact investment we received. For many of my colleagues, that US FDA approval was almost felt like a finish line, but actually that's only when the journey, I would not say starts, it's actually continues. And there's another big piece of the work that needs to be done here. It's how we translate the clinical data that were generated through very thoroughly done clinical trials into a community use. How do we make sure that the drug responds to the needs of the population, that it is accepted by the population, and that it is actually feasible to introduce it? And that's the reason why we engage into a pilot field implementation. And you may have heard a little bit more about us recently. In January, we, following the registration of our product in Ghana, we set up, or we launched our Momentum project, which was the aim was to deliver the medicine to around 65,000 people living in a specific district where the disease is still being transmitted. In parallel of this to that work, we are working very closely with the WHO, making sure that they have access to all the data to support guideline recommendation. We also submitted a dossier to have moxidectin added to the essential medicine list. And we're also preparing a dossier to support the work of the pre-qualification program, because these will all be enablers to access in the endemic countries. So The D in our company is really for development, but also for research. And this work is actually done really in collaboration. We are a product and development partnership that is also the sponsor of the medicine. We have all the competency in our development team to cover the chemistry, manufacturing control, the clinical, the non-clinical, the pharmacovigilance, the regulatory. But then we rely also a lot on partnership with a contract manufacturing organization, partnership with research institute. And without all those partnership, we would not have been able to do much. We are just a very small company. We are 27 at the moment. We do rely a lot on those partnerships. And then on the other side of the spectrum, we have this team that is working and supporting all the activity to make sure that the medicine will eventually go and get to the patient. This work was made possible because we, as I mentioned earlier, we were successful in raising money through some innovative ways, and like attracting some impact investors. And since then, we were also successful in getting some public funding and philanthropy. Maybe one day, depending on the product and the indication that we are following, we are hoping that one product that has a potential in a high income country, their profit could support then the access in a low and middle income country. But this is yet to be shown. So to summarize, we are truly focused on global health, like everyone else here, but we are just another part of the puzzle. We develop, manufacture, and support the delivery of the medicines. The portfolio that we have at the moment contains 2 medicines with a potential for 8 different indications. Very diverse indication, but often parasitic indication. I think the one I would like to mention, just because I realized, and I was the first one not to know much about it, is the second product, the Ramilast, at the bottom of the table, is a good candidate for a leprosy type 2 reaction. And leprosy type 2 reaction is actually a complication of a leprosy infection that is currently treated either by thalidomide or by corticosteroids. So those 2 options are not options that are valid. We should be able to develop better products, even for vulnerable population, people that often don't have a voice. And this is what we are trying to do with medicines development. This is putting back at the core of our activity the needs of people who often don't have a voice. Thank you very much.
Thank you. Thanks, Barbara, for sharing that all with us. I'd now like to introduce joining us online Associate Professor Misha Coleman.
Thanks and greetings, everybody. I've also got lots of good news, and I'll just focus on some of the financing innovations that we're lucky to be part of. Greetings from Meanjin, Brisbane, which I have a connection to because at 17, I started my training as a registered nurse here at the Princess Alexandra Hospital. And no, Tim, I've got no sedatives up this way, up this end of the country. I'm raring to go. We're working on expanding the scope of practice for nurses so that they can do colposcopy and enhancing the workforce. So my day job is to eliminate cervical cancer from the planet. Probably why I'm so energized. I'm going to mostly talk about financing today, but really the big game changer for the world is going from this soul speculum, which you can't see, it's a bit hard to see there. Everybody knows what that looks like. We went from a speculum, a cytology-based test, to a virus-based test, the HPV virus, which it's very hard to do this. And really, for working in developing countries, in hard-to-reach places, This technology has been absolutely transformational because we can screen and treat within an hour, and you can imagine the possibilities that that's opened up for us. So in terms of the financing though, really it was the connection that the Mindroo Foundation, Andrew Forrest had to Papua New Guinea that started this work, this model of screen and treat out in the highlands of Papua New Guinea several years ago. And I just want to sort of shout that out because it has been truly catalysing. So, you know, since that trust was placed in our consortium, we then had donor funding from the Asian Development Bank, private sector funding from Cepheid, the sort of manufacturer of the tests. And it's been truly not just catalytic, but it also helped us get noticed by DFAT, who've also put their faith in us. And again, in this second phase, we've now been able to take our model from 2 countries to 8 countries in the Indo-Pacific, thanks to the Australian government. And once again, that's also been catalytic. So, you know, our good friend Carolyn Kennedy heard about it, spoke to her mate Joe, and the Quad Cancer Moonshot got behind us, brought Mindroo into the tent again, and more recently, a private philanthropist, the Swire Foundation, has enabled us to expand that into an additional 4 countries. So we've gone from 2 to 14 in a very short space of time. So it's exhausting, but it's also great. And I just really want to shout out to the force of a consortia arrangement. Us here at the Centre for Cervical Cancer could not have done this without the leadership of University of Sydney. And I know Professor Nancy Baxter is here today. Thank you for your leadership, Nancy. The Kirby Institute, who are really on the ground delivering a lot of this work, and Family Planning, who are a really, really critical piece of our puzzle. Really, the next steps in terms of a global elimination effort are market shaping and pooled procurement. So in the same way that Gavi has successfully brought down the cost of vaccines, we really, really need a similar mechanism for the procurement of these little tests. These are about 12 to 14 US per test. So of course, a lot cheaper than, oops, lost my video. A lot cheaper than treating cancer, but really outside the reach of many jurisdictions. And I want to give another shout out to Prof. Adeeba and her vision, because she's been really behind the Malaysian effort to eliminate cervical cancer. And 2 weeks ago, she signed a public-private partnership with the Ministry of Health in Malaysia. And of course, that takes the work beyond the clinic, beyond the province, and really enables something at a true population level. Just finally, on the bright side of this, the fiscal cliff that USAID and many of the global health organisations are facing, Gavi, Global Fund, Unitaid, I wanted just to give a shout out to a very innovative financing mechanism called IFM, which Gavi set up, I believe, in about 2006, and they're really vaccine bonds, and we're probably the first, social bonds in global health. They've raised around about $6.2 billion for the purchase of vaccine in developing countries. And that's the sort of innovation, and that's the sort of reach that private sector capital, together with us all in the room, we can really achieve that. And before I go, and I want to give a shout out to Sarah Golding, who's going to be mortified and embarrassed at me doing this, but Sarah's just recently stepped down from a very long and successful career at DFAT as Deputy Chair on behalf of Australia for the Gavi board. She led some real change, as did Helen Evans, when she was in Geneva, around the recognition that the HPV vaccine is the most impactful in terms of life saves and cost effectiveness. And additionally, Sarah led the gender strategy development work that was recently launched at DFAT, and that is no puff piece, that document. It's got real juicy, meaty performance targets, which the rest of the program is now going to have to meet. And I don't know how they're going to do it, having lost you, Sarah, but thank you for your contribution. You are one of the greats of global health. Thank you for your leadership. Bye.
Thank you, Associate Professor Coleman, for your wonderful insights and also the enthusiasm with which you said them. It was very inspiring. I'll now invite Associate Professor Pete Lambert to lecture.
You don't have to zoom in too close. Yeah, thanks everyone. Thanks, Julia. I'm talking about inhaled oxytocin. Inhaled oxytocin is a Monash innovation which is directed towards addressing the single leading cause of maternal mortality, and that's postpartum hemorrhage. Oxytocin in its current form, the injectable form, is the standard of care to both prevent and treat postpartum hemorrhage, and consequently the WHO recommends that every woman at every birth receives a preventative dose. But there are some limitations to the use of the product in resource-poor settings, not least of which is the fact that it requires cold chain supply and storage in order to maintain quality through to the point of use. And of course, as an injection, it requires authorized and trained healthcare workers, in this case, birth attendants, and sterile needles and syringes for safe administration. So to try and overcome those limitations, what we have done at Monash with our partners is reformulate oxytocin into a powder which doesn't require refrigerated storage and can withstand all of the ambient temperatures that it's likely to encounter in tropical climates. That powder is then delivered through a really simple to use and affordable inhaler, and it delivers oxytocin into the body in exactly the same way as the intramuscular injection, which is the standard of care in resource-poor settings. So with philanthropic and public sector support and with partnerships with industry, we've been able to take this from an idea all the way through the preclinical and toxicological testing that's required into the clinic. We're at a phase 2 stage and we're about to publish our latest clinical trial in the next few weeks, journals permitting. But that's the opportunity. And unfortunately, that's a little bit where the optimistic part of my presentation stops, because now we have come to a little bit of a halt. We're treading water because we neither have an industry partner or a substantive source of funding to be able to progress the project. So I just wanted to talk a little bit about the challenges that we're facing, and they were prefaced pretty well by Barbara because they have the same challenges with neglected tropical diseases. So the main difficulty we have, particularly in getting a pharma partner on board, is that inhaled oxytocin has no real substantive for-profit potential within high-income countries. And the reason for that is that, one, there's relatively few births in high-income countries, but most particularly, the injection is a cheap product and it's effectively used in those countries. There's no issues with cold chain infrastructure or administration. And that means it's difficult, particularly for profit-making pharma companies, of which most of them are, with the exception of the people in this room, to justify internally investing in a product that is not going to be able to recoup those development costs with sales down the track. But it goes further than that. And perhaps unsurprisingly, given our first session today, there's a gender element to this. So when you look at pharmaceutical expenditure on R&D, only 1% of that expenditure goes towards conditions that affect women only outside of oncology. And that includes conditions of pregnancy. And then overlaid on that is the reluctance, let's call it, of pharma companies to get involved with doing clinical trials for pregnant individuals. And that's exemplified by the fact that of all the obstetric medicines that are used in conditions of pregnancy, only 2 were purposefully developed for that use. All of the other medicines are repurposed from other indications. So what we can intuit from that, almost by definition, is that the pharmacological care that women receive during pregnancy is actually suboptimal, because those products were never designed for that purpose in the first in the first place. And then the final part in terms of getting pharma company interest relates entirely to the business model that MDGH follow. Barbara's talked about the wonderful work that they do, and the financing from that in some substantive part came from being able to exploit the regulatory incentives that are offered for neglected tropical diseases, and in particular, the priority review voucher that gets issued by the FDA if you're able to register a product in that area. And that's a hugely marketable commodity that can be sold for tens of millions of dollars once received. No such regulatory incentives exist for maternal health. So we don't have the opportunity to exploit those. So this gives us some real challenges in our conversations. I mean, I have to say we have been partnered twice with pharma companies, big multinational global pharma companies. Both of them, when they had a change in senior management and decided a change in strategy, withdrew their support. So we're optimistic that there are companies out there, but we just have to have those conversations. Finally, just to finish, you know, one of the things we try to do to offset the challenges in those conversations is to find philanthropic support to help at least co-fund the development costs that we are going to face, to de-risk it for a pharma company that comes on board. But sometimes those conversations are also challenging because you're effectively asking a philanthropic body to give a large sum of money to what might be a hugely profitable global multinational pharma company to do something that perhaps we could suggest they might want to do off of their own dollar. But maybe I won't go that far. But anyway, I just will stop there. What I will say from an optimistic point of view is we still get hugely positive response to the innovation from people on the ground, from midwives and birth attendants. So we're still committed to this project. We're out there, and if there's anybody who wants to join us on the journey or knows people, then please, we're happy to have those conversations. So thank you.
Thanks, Associate Professor Lambert. I'm excited to see where that could go in the future. And I'll welcome back to speak Reverend Tim Costello, finally.
Thank you. Thank you to the previous speakers. I was in Uganda 6 weeks ago. Which one do I hit? That one. Okay. So that's forward, isn't it? Yeah. Yeah. In Uganda some 6 weeks ago, Kenya and Uganda, in slums in Kenya, clinicians who were all women in tears, the ARVs had literally disappeared from the shelves overnight, and sending away positive pregnant women, knowing that with ARVs they can deliver a non-positive child. They were in tears. I was in Uganda, and thank you, Professor Peter Lambert, for what you're doing with maternal health. The donor that I've taken in the last 8 years to northern Uganda has now built 4 hospitals. When we first went there, some 5 women a day in northern Uganda were dying in childbirth. As we know, in childbirth, 10% of women anywhere in the world will have complications. If you're here, you'll live. If you're in northern Uganda, where they were nurses with a torch in their mouth, delivering babies at night without a bed onto dirt floors, complications, you will die. Again, the extraordinary thing in these Ugandan health centres was the disappearance, thanks to USAID, of ARVs, of malaria and TB treatments. We literally saw it in real time, which is why I am in great grief. Well, the task for all of us at the moment is to keep hope alive. And one of the hopeful things is a campaign that has united the whole sector. So up the back is Marion Stanton. Do you want to wave your hand from Save the Children? And you can talk to Marion later about coming on board this campaign, which is a campaign over 3 years, safety in terms of addressing climate change, humanitarian aid, addressing the very issues of global health that we've been talking about. We all know the perfect storm, COVID-19, spiraling debt, rising inequality, cost of living crisis, the climate crisis, and I'm not sure what that one in the corner says. I can't read it. It's another one of the, do you know how to move that? I'm a dinosaur. I cannot, oh, there we go. Escalating conflict. And we know from Ukraine to Myanmar to Congo, which is just terrifying and off our radar at the moment, in Eastern Congo, in Goma, to Gaza. Escalating conflict has been the story. So what am I doing wrong? Oh, okay. So basically this shows the structural decline of Australia's aid budget since 2000 to 2024. The big drop was there, you can see, under Tony Abbott. A month before that federal election, Joe Hockey, then Shadow Treasurer, rang me and he said he wasn't taking to always ringing me, but he did. I've been reading the World Vision magazine. I'm a World Vision donor. You do a great job, Tim. That's when I got worried. Sure enough, in the May budget, $1 billion cut out of aid. So that dramatic drop you can see under Abbott, and which we've never really recovered from. We've been just flatlining ever since, dropping Australia out of 31 OECD countries to 28th in generosity. That's how low down the chart those figures represent. Now, do I do that one? Yes. What this campaign is asking for is a commitment to 1% of budget. At the moment, it's 0.68% of budget that we spend on aid. We'll see that defence is 7.16, and everyone agrees, it seems, that we have to increase defence. I often find myself saying, but not at the cost of aid. General Mattis, in Trump's first administration, when Trump was mooting cutting aid, General Mattis, head of defence, said, if you cut aid, you'll have to buy the military more bullets. Literally, true security lies with development. When there isn't development dollars, you get unrest, not to mention conflict and inequality. So really, we're saying that 99.32% is still spent at home. 1% of budget is not a bad ask. There's Australia right down the bottom of the OECD country aid as a percentage of gross national income. Now, US will be the very bottom, coming last, having, you see, different figures from 42 to 54 billion pulled out, but absolutely massive, nearly 40% of the aid development sector. So when we got Redbridge, and Tony Barry, who's a director there, is close to Peter Dutton. He's a former director of, I think, might have been Victorian Liberal Party. Anyway, when they did polling about asking Australians how much we spend on aid and getting 5%, 10% of budget, when they were told it's 0.68% of budget, the first response from just about all the respondents, Redbridge told us, was embarrassment. We are so embarrassed. Is that right? The second response when it was put 1% of budget was absolutely, of course. So we actually have very strong polling that when Australians are informed, there is support for this. What we have been doing at Micro Australia and the other aid agencies are doing it is constituent lobbying. In the last 2 weeks, I've been in every capital. We've been having women pastors and women church leaders meetings. Now, these often are very conservative gatherings. Over 2,000 women in the last 2 weeks. It is amazing to me how passionate they feel about aid being increased to 1%. From very conservative backgrounds. Women have EQ and empathy and this sense that this is wrong. Profoundly wrong for a so-called pro-life Republican Party in America to sentence so many to death, literally by smashing aid. And I think it was Brendan and Burnett's research showing that There's going to be 10 million HIV cases thanks to USAID withdrawing in the next decade, and 3 million deaths over the next 5 years. A death sentence from pro-life Republican parties. These women who have been going around the country this year, and they're joined by other aid agencies, get a remarkable response. You know, as a former president of the Baptist Union of Australia, for 3 years I'd go with church leaders often to Canberra, and some of the church leaders, who happen always to be men, some of them were okay, but you always noticed how it was chest out, legs under the table, telling the politician about the size of the church program and membership, and the politician's eyes glazing over. I thought, we've got to do something differently. Let's take women from churches to visit our politicians, which we've been doing for the last 5 years. It's amazing. It's a totally different response. The women with EQ and passion, advocating for people who won't ever vote in Australia, but whose lives often depend on all that we do, they get through. Politicians are riveted. We have been doing these electoral events, and you'll see all these women fired up. There is a constituency here. I'm very proud that all the Christian faith church heads of churches wrote to Peter Dutton and to the Prime Minister 3 weeks ago, pleading not to cut aid, to increase it to 1%. In the budget, I was up there, aid increased by $136 million. I was texting our Foreign Minister and thanking her. Of course, it's a little bit unfortunate that part of filling the gap with USAID was deferring some of the payments to the Global Fund, and that's not good. But it's such a massive gap. At least we didn't cut. What we now know is that, this is some of the church leaders and me in Canberra on budget day, so just last week, with some of the aid leaders in the other picture. And on budget day, we had, besides some church leaders there, Salvation Army, Uniting Church, Pentecostal churches of Australia. What's really interesting is from the left to the right of the church has politics right through it. From the very right, the Australian Christian Lobby, to the left, I don't know what's the left, maybe the Uniting Church, all of them are absolutely signed up to not cut aid, to increase it. That's a constituency which surprises politicians. And there's Brendan, and that's why that picture's there, of course, addressing one of our rallies. So the Safer World for All campaign has been launched. It continues. We have Redbridge polling that says to politicians, there's actual buy-in from the electorate. Keeping hope alive. Please join us. Speak to Marion, who's up the back, if you want to be part of this. This is still where our hope lies for some protection. I should add, we don't know what Dutton is going to announce. We've got to him, we've got to Andrew Hastie, we've got to David Coleman, the Shadow Foreign Minister, and they don't want to cut aid in any cultural war, Trump-type sense, but they won't commit. They won't commit at the moment. They will have to in this election, what their policy is. Are they going to increase defence by cutting aid? We just don't know there. But we certainly have had these church women and others in their ears saying, we are watching. This is important. Thank you.
Thank you very much to Julia, to Tim, Barbara, Pete and Misha earlier for all your efforts, for your passion and also your leadership. We are now moving to the final part of our day. I'm really delighted to launch and introduce the speakers of the Lancet Commission on Oxygen Supply. A few weeks ago, when we were negotiating the program for this conference, we took the opportunity to reach out to the Lancet and to see if they'd done an Australia launch or not. This report had been launched a few weeks ago globally, and most importantly for you to know is that much of the intellectual expertise and efforts came as much from Australian authors as it did globally. These are global commissions that take some years to form or some months. So it's really my delight for the next little while to introduce a speaker who represents all of that commission. It is Associate Professor Hamish Graham, who is an Associate Professor of International Child Health at the University of Melbourne and paediatrician at the Royal Children's Hospital, which is just down the road. And he and his team and part of his team and others are here with us today. They have left some reports at the back of this room if you want to take a Lancet report back home with you later. But for now, I would like to invite Hamish up to the lectern, and thank you so much for joining us.
Thanks, Selina, and it's lovely to be here with you all. As Selina mentioned, we've got copies hot off the press. I just received them from the Lancet offices last night, so there's copies up the back if I do inspire you enough that you want to go home and read more. So in this last session, you've heard some hope and you've heard about some exciting new medicines. I'm going to tell you about one of the oldest medicines, which still has woeful issues with access globally, and hopefully leave you a bit inspired about why this should be a global health issue of importance, and maybe even have a few connections to the work that you do and in terms of how you can help the Commission and help all of us working in this space sort of move this forward. So the Commission starts with, I think, a statement that you'll all agree with. Oxygen is an essential medicine. It's an essential service required by millions of people, from newborn babies through to elderly people, and it ought to be available to anyone whenever they need it. The Commission then goes through and unpacks the issues that stand at the moment and what it's going to take to change it. And I guess the fundamental thing here is something that we've heard come up multiple times today, in that it takes a systems approach. Now, in conducting the Commission, one of the wonderful things was the buy-in that we had from a lot of community and a lot of community voices. So I want to start with just sharing some words from Aggrey Aluso, who during the peak of the COVID-19 pandemic lost his father to COVID. And he tells the story of his father getting sick with COVID, struggling to breathe, going to hospital, being put on oxygen and doing pretty well. Aggrey saying goodbye to him as he went home for the night. And then that night, his oxygen supply running out, and in the period of time that he wasn't getting oxygen, deteriorating and dying. But in this clip, you'll hear Aggrey describe him as one of the fortunate ones. Now, in the report, and I'll touch on some of this, we talk about some big numbers, but I really want you to hold on to that story, and you can imagine many other people who has had similar experiences. Now, I mentioned that oxygen is one of the oldest medicines that we use, and in any hospital here in Melbourne or here in Victoria, it's absolutely taken for granted. Oxygen comes out of the wall. We know healthcare workers know how to use it. If you're ever sick enough to go into hospital, you're sure to get a pulse oximeter probe on your finger to check your blood oxygen level, and you'll get oxygen if you need it. But sadly, that's not the case for most people around the world. Oxygen really wasn't on the global health agenda until COVID. And it was during COVID that we started seeing these sort of headlines of hospitals closing because they'd run out of oxygen, of patients literally lining up for hours to get their own refills of oxygen, and many tragic stories of patients dying, of healthcare workers needing to make decisions about who do they prioritise for oxygen, who are they going to give the limited oxygen to. At the time, there was a large response through the ACT-A Oxygen Emergency Task Force, which was part of the emergency response for COVID. And over about a year period, there was over $1 billion mobilised. And this was phenomenal, but it was also deeply flawed. This response didn't really start until a year into the pandemic. 90% of the funding went towards equipment, sending equipment in, and much of the equipment never arrived until well after the peaks of COVID had passed. And in an independent evaluation of this response, you can see here that the feeling was that oxygen would not have been neglected like this either before COVID or in response to the pandemic if there had been more country representatives from low and middle income countries. Now, within the pandemic, there was also a very unique opportunity to put oxygen on the global agenda and start making some changes. And I've put a few things here that came out of that, including our work for the Lancet Commission. But aside from that, there was a new global resolution put through the WHO in 2022. There's a new coordination body, the Global Oxygen Alliance, which is up and running and doing great work. And there were a lot of new actors and a lot of new innovators coming into the space. Now, in the next 10 minutes, I'm going to give you a quick run through of the Lancet Global Health Commission, what it was about, what we're asking from different communities, including global health communities, and then hopefully leave you with a few things to reflect on in terms of the broader themes for today. So very quickly, a Lancet Commission is a scientific review, inquiry and response to an urgent and perhaps neglected or understudied health predicament. And the key thing here is it's science-led, but it's multidisciplinary, collaborative and truly international. For us, we started this process back in 2022. This is a snapshot of what it looked like for us, so you can get a sense that it involved a lot of different academics from different disciplines, but also a lot of people in NGO sectors, UN agencies, and consultations with caregivers, patients, industry, as well as, importantly, governments and health ministries. This took us through to the launch of the report that we've got here today just about 5 weeks ago. It's still very hot off the press, but very much a lot of the work is really just starting now. So if you go on the Lancet website, you'll find the report. You'll find a whole bunch of other things as well, including commentaries, a little podcast, country case studies, policy briefs, all the patient and caregiver testimonials, including the one that I shared earlier. And our task as the Commission going forward is now to take this report and make it accessible and make it owned by everyone. So we'll be doing a series of regional launches throughout this year, and today is the Australian launch. So very briefly, to touch on a few of the key findings coming out of the Commission. The report steps through these 5 areas in a lot of detail, and I'm only going to be giving snapshots today. So let's start with very basic questions. Who is it that needs oxygen? This headline figure of 374 million people need oxygen is what we've come out with out of the Commission. And you can see the vast majority, 80%, live in low and middle income countries. To get these numbers, we use global burden of disease data and mapped out for all the relevant conditions how many people are likely to need oxygen. And you can see that then we broke it down by different regions. And probably the main takeaway here is that the 3 biggest bubbles, the 3 regions where there's the most people needing oxygen, Sub-Saharan Africa, South Asia, and the East Asia Pacific regions. And I want you to remember those 3 areas when we get to talk about the coverage gaps. We also know a lot about who needs oxygen, and this is a huge variety of patients. So this includes people of all ages, from newborns born prematurely or with sepsis, right through children and adults with a whole range of both respiratory and non-respiratory conditions, all the way through to elderly people who may need oxygen for chronic conditions, and of course, all those who need it for surgery. And I make this point because oxygen is one of those things which has really fallen through the cracks, because it's not just one person's business, it's everyone's business, and so it becomes no one's business. And one of the things we're trying to get with the Commission is to say, whether you work in maternal child health, whether you work in maternal health or child health, whether you work mostly with elderly people, whether you're a TB person or a HIV person, oxygen and strengthening oxygen systems is relevant to you. The other big thing we looked at in terms of who needs oxygen is what happens during humanitarian emergencies. Obviously, we saw during the COVID pandemic, there was a huge increase in oxygen need, both because of the numbers of people getting sick with respiratory illness and also who those people were. So generally adults who need larger volumes of oxygen, more respiratory support. But it's not just respiratory pandemics and respiratory epidemics which affect oxygen access. It's also many other humanitarian emergencies. So whether it's conflict disrupting health services, whether it's natural disasters cutting off access to areas, these can all massively disrupt oxygen supply and oxygen services, while at the same time increasing the need through trauma and other illnesses. There was this lovely quote from one of the people who gave testimony from the Philippines, just talking about their experience bringing their loved one during the COVID pandemic, bringing their loved one and trying to get access to basic oxygen services. So in the Commission, we put numbers on this, and it's very big numbers, difficult to handle, but it's almost a doubling of the number of people needing oxygen for acute medical conditions during COVID than in a usual year. So it can be really, really massive. And I guess the key takeaway here is oxygen needs to be front and center of any pandemic preparedness and humanitarian response plan. It hasn't been in the past. I don't think we've learned the lessons from COVID well enough yet. So that's who needs oxygen, who is currently getting oxygen. So we looked at oxygen, availability of oxygen and patients getting oxygen across the whole world, mapped that against who needs oxygen, and came out with this startling statistic that less than 1 in 3 people who need oxygen will currently get it. And to put that in context, there's many other medicines access and treatment access things that we regularly track, including here I've got for TB and HIV. They're both sitting at around 75, 77% coverage. We're talking about 30% coverage for basic oxygen services, an enormous gap. We also learned quite a lot about what is the cause of this gap. And I guess the big take home here is it's not just about supply, even though that's what everyone has been focused on. So we looked at those who require oxygen for medical needs and mapped it against this effective coverage cascade. And on the left, you can see the number of people in low middle income countries who need oxygen. On the right, you can see who's actually getting it in any sort of a safe and effective way. And in between, you can see where the gaps are. So the first gap is some patients just don't make it to a facility which ought to have oxygen in the first place. So this is contact with service gap. The second gap is they get to a facility that ought to have oxygen, but it doesn't even have basic oxygen services. The third gap is you get to a facility that has oxygen services, but for whatever reason, you don't get it. The biggest thing being you're not actually recognised as needing oxygen. And then the fourth gap is where you get to a service, you're lucky enough that they've got oxygen, they recognise that they need it, that you need it, they give you oxygen, but for whatever reason you get it in the wrong way, it's not safe, or in the case of Agria Luso's father, it's interrupted and you don't actually realise the benefit. And I suppose the take home here is that a lot of the issue is about how the oxygen is provided and the capacity of health workers to be able to provide oxygen. It's not just about oxygen supply. And you heard I said during COVID, 90% of the funding went just to getting equipment in. It was entirely a supply-focused response. The other take home from here is that we broke it out by small facilities and large facilities, and that's what you can see, the two sort of coloured bars. And the drop off along the cascade in smaller facilities is much larger than in large facilities. And this is one of the inequities that we saw throughout the Commission, that so much focus was on the largest facilities, which were actually already doing pretty well, and not on the smaller facilities where the majority of patients were presenting and which faced the biggest challenges. Now, we also looked at this for surgical conditions, and I guess the thing here is the main gap in medical oxygen for surgery is people not getting surgery in the first place. So people having a need for surgery, a need for oxygen for surgery, but they're not being surgical facilities in the first place. Operating theatres in general are much better set up in terms of oxygen than other wards. All right, so briefly, just to touch on inequities, we saw big inequities between regions and between countries, and you can see the regions are specified here. And if you think back to that map, where was the biggest need? It was in Sub-Saharan Africa, South Asia, East Asia Pacific. Those are also the three regions with by far the greatest issues in access at the moment. You can see in Sub-Saharan Africa, less than 1 in 10 people who need oxygen, in this case for medical conditions, will receive it. But there were also a lot of inequities that we uncovered within countries. I mentioned lower level facilities versus larger facilities. There's also inequities at ward level, so intensive care, adult wards tending to have much better access than paediatric wards, neonatal wards, general wards. There are big inequities between rural and urban areas, between government facilities, private facilities, and I'm sure much of this is familiar with you. This is not just oxygen, this is healthcare access in particular. But it does tell us where the efforts ought to be focused. They ought to be focused in the smaller facilities serving poor and rural populations, and that's certainly not where the bulk of the funding has gone to date. Now, I'm not going to spend much time talking about oxygen cost, except to say that there should be no doubt that investing in oxygen services is cost effective. In the cost effectiveness data that's included in the Commission, it matches up against the most cost effective child survival initiatives, and on independent modelling that's come subsequently, there's an estimated return of $21 for every dollar investment in oxygen. So the question is really not should we invest, but how should we invest? Where should we put that money towards? So to bring us to solutions. When we approached solutions, we were very aware that all the attention to date and throughout COVID had been on supply. So we started by trying to map out what do we actually have to be thinking about? And in this quite complicated diagram, I hope you get the sense that yes, production supply of oxygen is part of the picture, but there's also another part of the picture which is about how patients actually get to that point of getting oxygen, from care seeking, from pulse oximetry, being able to detect who needs it, through to the people and the things that you need at the bedside. Behind all that is how all of this is coordinated. So this is governments that actually have plans and are able to manage it, and the idea that oxygen needs to be integrated across all your vertical systems. And then finally, there's the global agencies and the regulatory authorities that can either facilitate or hinder a lot of these access issues. So to touch very briefly on some of the key oxygen solutions, we described 5 different areas of action that are needed. First, there needs to be action around linking patients to care, and we see pulse oximetry and increased pulse oximetry implementation as really key to that. So this means having pulse oximeters available that are age appropriate at every point of care, that it's integrated into workflows, into curricula, and that it's pushed out to smaller facilities to help get those patients identified earlier and to the place that they need care. Secondly, the big area is around building resilient medical oxygen systems. And you've heard me say it already, but this is more than just supply. It's more than just increasing supply and production. It's establishing resilient oxygen production, storage, distribution, and delivery systems that will enable, whether it's a large facility or a small facility, urban or remote, there to be 24/7 access to oxygen for every patient who needs it. Thirdly, there's a question of how all of this is coordinated. And there's been some really great progress in this area, particularly with the development of national oxygen strategies. And this has been already picked up well by WHO. Fourth, there's a lot of activity needed around strengthening medical oxygen regulation and markets. And the key ones here I want to point to are better pulse oximeters that work on everyone's skin, not just light-coloured skin, and also regulations around liquid oxygen so that it's not dominated by just a few multinationals. And finally, as a researcher and someone who wants to measure whether any of this is working, we need to monitor for impact. The current indicators and data that we were trying to work on were woefully inadequate. We'd known that for a while. But we have proposed new indicators, including a policy scorecard that's been taken up by WHO to help countries be able to report their progress back against the World Health Assembly resolution. And finally, none of this means anything if it's not followed by action. We articulate recommendations for a whole group of different stakeholders, and I was going to pick out just a few things for this audience here, but I might just skip through this a bit quicker. There's a whole list of recommendations for each of these sector groups, and probably some of the takeaways I think for audience here is national oxygen plans is something that's going to be really pushed by WHO. So it'd be great to get as many people on board with that and supporting countries with that. So whatever sector you're working in, the oxygen plan, national oxygen plans should be should be integrated with that. Now, we finished the commission with this very optimistic statement, which sounds probably even more optimistic in the context of everything that's happened since this report was accepted for publication. The idea that national medical oxygen systems can be an exemplar of how we want to do global health, involving communities, working in partnership and towards sustainability. I do want to keep hoping that this is achievable, but it clearly won't be with business as usual. So in putting together these slides, I thought I'd just finish coming back to an idea that I said at the start. The idea that medical oxygen was an enormous global health blind spot. I remember a panel I was on with Dr. Fauci in the first year of the COVID pandemic, and Dr. Fauci, who was leading the US COVID response, who spent his entire career advising on how to respond to emergencies around the world, admitted frankly that oxygen had never been on his radar. And I think this was true of all the global health agencies and many people working in global health. But it makes me wonder, what are the other global health blind spots that we have today? How receptive are we being to grassroots-led priorities? Coming back to comments made earlier today, how well are we listening, not just up, but sideways and down? And how good are we at amplifying the local voices when they identify problems, things that are happening, things that need to be borne witness to? It strikes me that a lot of what we discovered through the commission was global health not working the way that it should, that the bulk of funding being decided in high-income countries going to high-income country NGOs and businesses to send stuff in to the places it was lacking. And to me, this is not the way that we're wanting to do global health. So I thought I'll end there. I think this has come up already today, and Prof. Avimbol's writing about this is very, very good. There is no global health without justice. And I think in everything we do, certainly in the work around that I've been doing around oxygen, that's certainly the case. So I'll finish there, give a big thanks to everyone who's been involved in the commission, including people here, including partners in many different institutions around the world. And I hope that you can all join me in being a bit of a champion for oxygen going forward.
Thank you so much, Hamish. And first, congratulations for getting this report out. It's so important and critical. And secondly, for communicating it so clearly. For those of you who haven't attended a Lancet launch in the past, usually these launches take even longer than what we have just experienced together and involve multiple panels and many angles, but you captured it so beautifully. And I hope for those of you online and here who are interested in oxygen supply or making those connections that you talked about at the end, that you can reach out, to Hamish and the team here. I think I can, quite aptly say that the Lancet doesn't commission these reports for them to sit on the shelf. They like to have a very active post-publication life. And I think by exchange in this region, we can help Hamish and the team in their endeavour to have more activity in their post-publication life. So to go to the final part of our day together for the formal proceedings of the Congress, we at the Australian Global Health Alliance are trying to build platforms and engagement with sectors outside of health, with government, with the arts sector, and with private and philanthropy. And we know that to reach our objectives in health, now more than ever, we need new allyship. So it was in that vein of thought that we invited the last speaker, who is actually on record and is joining us from originally it was Nairobi, then in Beijing, and now in London. So she sent us in her recording while we were sleeping. While the team beside me bring up her recording, it'll only go for a few minutes. Hannah Ryder is the CEO of Development Reimagined. I first met her with Professor Shane Bimbala on a Wilton Park-led global dialogues on decolonisation of global health during the pandemic. Development Reimagined is an independent, African-owned and African-led international development consultancy with offices in Beijing, Nairobi and London. Hannah is a former diplomat and economist with over 20 years of experience, and she was named one of 100 most influential Africans in 2021. She sits on various boards, including the Environmental Defence Fund. She's a member of the United Arab Emirates International Advisory Council on the New Economy. And prior to all of this, she worked on UNDP programs in China to help it scale up and improve its cooperation with other developing countries, including in Africa. She's held a number of advisory roles for the UN and OECD and co-authored the seminal Stern Review of the Economics of Climate Change in 2006. We really wanted her to share her work for a little while with you so that you could also be exposed to the great work that Development Reimagined is doing in the area of development as we reimagine what our present and future could look like. So hopefully we've got a recording. And then after that, I'll hand over to Brendan for final words and we will go for some refreshments. Good. 1 second. And so in credit to our team here, we only received this recording while we started this this Congress. So we're hoping it works well. And if not, I'll send it to you in your emails. Oh, she's here. We'll give it 2 minutes. Yes, start again. Brendan, get ready to come up in a minute. You should hurry up. No? Okay. It's not good. No, shortcut it. Okay, apologies for all of you that registered. We will send you the recording, and I apologise for that glitch, but that's life. So you'll be happy to know, for those of you in the room, this will mean that we will get to our reception and refreshments quicker. But before we do that, I want to hand over to Brendan to give closing remarks and thank all of you for joining us.
I have the same delay as you see up there, but I'm in person, so I have no excuse for it. What a day we have had. What an afternoon we have had. You know, we started the day and by no means is this gone, but in a sense of grief and despair. And of course, we're not going to magically turn that around. But I must say, I have ended with a strong sense of hope. That was a great word, and it's come through in every talk, but also quite literally, Tim, in yours. You know, I'm quite into nuance. You know, I'm not a black and white person. I don't see a polarizing position generally. But I think fundamentally we are now in a war. And by definition, that means there are sides. I think there are sides. The two sides are one that is fundamentally supporting a selfish philosophy and one that is not. There'll be grey in between that, but effectively that's the war that we're fighting now. And what I've seen today is, and perhaps the greatest source of hope, is that the side of unselfishness has assets that the other side will never have. They will never have them. It doesn't matter how much money you have. We have to identify those things really well as to what they are. We heard of some of them: empathy, compassion, science, and all that means, community solidarity, sense of positivity about our community and about the future, public good, and all that means for successful societies and in our world, in the global health community, for health. Perhaps the greatest asset we have is each other. That in all of its sense, but the talent that we saw today, the compassion and the sense of allyship in applying those assets together and for the benefit of each other. So somewhere in those assets, I think this unselfish majority, and we are a majority, it's come up a bunch of times, you know, whether it's a survey that says, hey, you know what, most Australians actually do want to give, they want to give a lot. They just don't realise we're giving such a tiny amount. So they might say, oh, we want to give less, but they think we're already giving over 10% of it. There's all sorts of ways that you can discover that the majority are in that unselfish camp. They're on the side of right. So, you know, identifying those assets and applying them give me great hope But the challenge, of course, as we started today and as ran through the day, is profound. At very dark moments in which we live. So thank you to everybody who attended. Thank you to all of those online. I know there are many of you. Thanks to those of you who are here in person. Thanks particularly to Georgina, to Prableen, to Selina, and to Raylene. There's an awful lot of work goes into an event like this. I think it was a triumphant event. Some of the things, I'm deliberately stopping myself from going through each one. I'd love to talk, Hamish, for half an hour about oxygen and the triumph that is, and the work that you and the team are doing. And I could have said the same thing about every talk. I feel totally inspired by today, and I hope you do too. We have to find a way forward, and we have to find a way forward together. So thank you very much.
Please join us for some refreshments behind again. And there'll be a new crowd coming in, but hope that all of you can stay for Shay's really wonderful book that I've read several times now. And we will be discussing that, I think, if my team allows. We'll start at about 5:45. Is that all right? Thank you so much, and go forth and have a refreshment. Thank you.
Well done.
Thank you so much. Yeah.